identify the set type and detect abnormalities. Of course, we have challenges in this, and some of the challenges is what is time consuming. Manual analysis, pattern turnaround time, and talk about the variation interpretation, workload pressure. In fact, when I was doing my training in UCH Ibadan some years back, we do call hematology lab a factory. You come around 8 a.m. You not lift up your head till 4 p.m. And if you are doing call that day, from there to blood bank, because you must do what? Both film reading, WBC count. That time the machine is having an issue. Sometimes you can see that when we talk about this film reading, we are lacking expertise, people that are experts. It's only few people we can see that are World Health Organization accredited micro years that can do all those things. So these are actually some of the challenges. And artificial intelligence will go a long way to help us, to aid us. Now let's go on and ask ourselves, what do we mean by that word, artificial intelligence? Look at that word, artificial. If there is an artificial, there is an original. The original is the human being. So you are bringing your original, transferring it to a machine. It's called what? The artificial. So the simple definition is that a human being transferring your own intelligence to the what? To the machine. And it turned to be what? An artificial intelligence. You can see what that young man is doing there. Now, let's talk about the operational definition of artificial intelligence. We say it's a set of technology that enable machines to mimic human intelligence. Is the set of technologies that enable machines to mimic or imitate machine. The process of simulating human intelligence by machine, which enable them to perform human-like tasks. Like the initial time I heard about artificial intelligence, I was not really interested, because the way the picture was showing is they want to turn as if I was seeing it as devilish or demonic, sincerely. But recently, my eye got open and realized that we need it in all areas of life, if in all the fields. And now look at the features. One, you should know that it's a technology. Second one is a process, or what? A product. And it involves machine, non-human entity. And this machine also need to perform a task normally that a human being ought to perform. So, in another word, imitate or mimic what? Human what? Intelligence. Now let's talk about the mechanism of artificial intelligence. There's something you should note. One, that the technology or the computer has no mind of its own. It must be operated by human being. The laptop or the computer will not just begin to perform something without somebody operating it. And what do we do? Humans that have the original brain, that have the original intelligence, we do what? We now train that artificial what? Object in how to carry out a specific task. We human, we are going to demonstrate it. How we are going to train it to perform what? A specific task. And so, and this artificial intelligence involves knowledge base. It's a knowledge base. It's a good knowledge base that is provided the artificial object as well as step-to-step procedure, known as algorithm, as the keynote speaker said yesterday, from which they solve problem. So the result is artificial object building what? Intelligent. Now note this. the more the artificial object has access to big data, like the keynote speaker said yesterday, is all about database, knowledge base. In the knowledge base, the better it is what? Solving what? The problem. So, now, these are some of the terminologies. These are a few ones that will actually link us to what we have. Algorithms are instructions that enable the machine to analyze data, perform tasks, and make what? Decision. Now look at this machine learning. We are gradually going into what we have today. Is getting a computers to learn and act as humans do. Machine learning, you are training the machine to learn. The word machine learning. The machine is what? Learning. And the computer will learn and act as human beings do. And how do the machine carry it? It uses the data which you give to that machine, the algorithm, to imitate the way human beings learn, gradually involving its accuracy. The simple thing we are talking about is this. Like in film reading, of course, when you have the microscope, you need to view to know whether, if you want to view malignant cells, you'll be able to view whether it's a leukemic cell or even malaria parasite. You view it to identify. And of course, like the keynote speaker said, if we have different people trying to view, we may have different results. But at this point in time, we want to get a particular data, either malaria parasites and everything, in large quantity and train them and put them in a system that immediately you get a malaria parasite slide and put it in the model we train, it will easily identify that there is malaria parasite. And so we provide the machine with the ability to automatically learn from the data and pass its brain while identifying the pattern to make prediction with minimal human. So now machine learning model. A machine learning model is a program that finds pattern, make decision from the previous unseen. Now example, we talk about blood film recognition. A machine learning model can be taught to recognize normal or abnormal cells. We are going to use normal paint as an example, but it's something we can also apply. And so we say a machine learning model can perform its task by having it trained. It must be trained with large data sets. Now look at the application. So get ready if you have a laptop, because we are going to enter into a serious practical session. One, stages of implementing machine learning model. The first one is you need to definition of the problem. What do you want to solve? Or value position. What do you want to solve? What are you having in mind? For example, the one we want to do now, we want to deploy a machine learning model that will differentiate normal cells and leukemic cells with high accuracy, providing a versatile tools for research and what? Diagnosis. This is actually the problem. You can also think about your own problem definition. If it's a microbiologist, or you want to actually identify the segment of urine, the particles of urine, what do you see in the urine? You want to actually differentiate it with the normal urine. Talk about histopathology. You want to differentiate all those malignant cells with benign cells, and then with the normal cells. These things are the problem. Now, the second step is what? We need to have a data collection and preparation. Is there we have that data we are talking about. Now, you need to go to a well-confirmed test. Since we are talking about leukemic cell, we need to go to a result of a well-confirmed leukemic cell slide and download them, put them in a particular folder for us to train them, and get also a confirmed normal set as much as possible. Remember, the larger the data sets, the more accurate the results. So after that, we prepare for the data set. Then the step 3 is what we are going. Then we go to the what? Model training. We have a lot of teachable machine, but the one we want to use is a teachable machine with Google. So if you have a big thing there, you can go along with me. Let's go to the training. So you can copy this website. Go to your Google, put it there. I should go back. I hope you are seeing the teachable machine.withgoogle.com. Do you all get it? Do you all get it? Can we proceed? So copy it and go to Google and place it there. Can we proceed now? So when I put it in Google, this is what I have. Teachable machine. Check whether I have the same thing. You can see where it says train a computer to recognize your own images, sound, and pause. Can we proceed? Please answer me now. Can we proceed? Good. Now with this, we just go to get started. When you click as get started, this the picture is going to show you. We still have other items. Then you go to image project because you want to recognize what? Image. You click there. The standard image model. You click as standard image model. I hope I'm not fast. Am I fast? Use your laptop. Your laptop will be better. Can we proceed? After logging in, this is what we have. When you say get started, you go to image. From image, you go to what? Standard model. This is what you have. When you go to what? Standard model. We have class 1, class 2. So we can come to class 1 and then put leukemic cells or leukemia cell. I don't know which one is correct. Then come to 2 and call it normal blood cells. After that, I have uploaded some data in my folder. enter the database. This is the little database I could get for leukemic cells. So what do? I have them there already. You go to this place and say upload. If you have it in your Google Drive, you can go through Google Drive, but I have it in the file, so I can click here, upload here. So the more you upload, you can see them appearing. We keep on uploading. Just because of time, we are going to just upload like 4 or 5. But like I said, the more larger you have them, when you have larger database, become more accurate. So this is the leukemic cell. Then I can go to the normal cell, also upload the normal cell. Let's still get 5 because of time. Okay. Having uploaded this data, you can see the leukemia cell, this is the normal cell. Then you come to this side, you see the train the model. Remember, we say it's what? Remember, I'm the human being bringing my original intelligence, transferring to the machine. Now I can say now, train. It says training all those models. It's still training. So we can upload as many data as possible. Also, if you want to differentiate different kinds of leukemia, the acute leukemia, the chronic leukemia, you can also use this pattern to differentiate them when you want to diagnose them. Also, if you want to differentiate a lot of slides, this is actually the model we use. I hope our network is still responding. Preparing the training data. The training is still in process. So it's counting now. Okay. See the training going on. Good. Model trend. So if you want to test the model has been trained already. We want to test this model now with some samples. Then you go to upload where you have the sample. Either the one you view through the digital microscope, or you save it somewhere, or you can also do it direct and send it there. Yes. Look at what it shows us. Leukemic cell, 98%, while the normal cell, some percentage. Let's check another one. Let's see the result of this. You can see this one. Give leukemic cell nothing, but normal cell what? 100%. Because we have tried the model. Anything we input now, we interpret whether it's a leukemic cell or what? Normal cell. Now when you have finished this, what next do you do? You export your model. You can see where export is. You export what? Your model. At this export of model, they can upload your model here. After uploading your model, it's going to bring a link. Yes, model uploaded. This is the link of your model you have trained already. You can also download it and have it in your this thing. Now this is the link, the uploaded model. So this is the link, you copy it. When you copy it, you can share it to others to use or connect it to a system. Now having copied it, now you can go to another browser to check how it looks like. You can copy it here now and check how your model will look like. So I don't know whether it's a network that is delaying the whole thing, but I hope you are following. So this, copy another thing altogether. So what we want to do, we want to test the model we have trained already. If you put it in another browser, how does it look like? So you can see it. The model I have trained. So with the link, I can send it to other people to use it as their diagnostics or what? As their research. What you need to do, if you want us to test it also, you can go to file, like we did before. We can upload whatever you want to upload as we did before. It will give you the result. Or you connect it to a device. If you connect it to a device, let's assume you have the digital that is connected to a laptop, and then when you view it and you upload it with that device, it will give you the result you are looking for. So this is actually the way we can apply artificial intelligence in what? In film reading. And I want to tell you that we have this some of the machine that is on board already that they are using in the Western world that shows that this artificial intelligence is actually on board. This is one of the machines I want to show you, this scan, and they have a lot of them which you can analyze urine segment. Good. You can see transform a clinic with 5-in-1 diagnostic. And you can see that with this machine, what happened? I'm almost concluding. Okay. We With this machine, you can analyze digital cytology, FICA, that is AI blood smear, and dermatology in the skin. You can also analyze urine segment. They use the same model we use. If you're able to train them and put them in a machine like this, see, it will be very, very easy. When you put them, be able to get an accurate result. And so, I want to appreciate, I want my special appreciation and thank to Almighty God, the pillar of my life. Special appreciation to our mentor, VC, the person of Professor T.C. Diaz for the platform he gave to us to operate. I thank my acting HOD, Dr. Iagoro, for believing in me. Thanks also Professor Ifoma Adikule for sharing the AI advert in our platform and her encouragement for the members of the staff to join. Finally, I want to appreciate Professor Peter Okebukola for facilitating this free AI training. Thank you very much. You can see we want to shake hands with AI and transfer our intelligence to have what? Artificial intelligence. This is actually the certificate we award for that artificial intelligence training. Thank you very much.
Thank you, thank you, thank you. I think that applause is not enough to appreciate our resource person for such a sound presentation, especially as it has to do with artificial intelligence. That is the in thing now. All right, thank you again. While we are sitting tight, we are getting set for the next presentation. We actually want to appreciate our Dean, Faculty of Medical Laboratory Science, for envisioning this program that has pulled us together to share knowledge. All right, the next presenter he is an Assistant Director of Medical Services, Federal Medical Center, Yeneguam. He is also the founder of ZIB Healthcare Development Initiative. As we speak, he is currently a PhD student, University of Benin. Is not a person than our vibrant scientist, and the person of scientist Zebedee Loveday Odu. Please, with a clapping ovation, let's make welcome our second presenter for the day. Please, media, get a slide up.
Good morning, everyone. My name again is Zebedee Loveday Udu. Permit me to stand on the already established protocol from yesterday and also the ones my senior friend, my senior colleague and elder brother, Dr. Emmanuel Honora, has also observed today. It is a great privilege and honor to stand here to do this, and I see it as a sign of growth, because even as a child, when you notice that you are getting new clothes, the older ones are no longer fitting into you, you begin to tell yourself that you are growing. So for me to assume this position, for me to stand here, to hold this mic, and for my senior friend in the person of Dr. Aguru, who is the Dean Faculty of Medical Laboratory Science, Federal University of Otuoke, to find me worthy to deliver on this task, I see it as a sign of growth. So I hold this in a greater measure, and I want to thank the VC and every other person that must have seen this program come true. Very quickly, I don't know the time allotted to this, but I have some slides, and I think even if I'm not able to flash those particular slides, it will help us greatly. After now, we'll get to look at them. I'll be speaking on standard operating procedures and clinical importance of bone marrow film reading. Bone marrow film reading, it is a very important component and aspect of our practice as medical laboratory scientists and also as hematologists where I belong. Each time I want to explain or I want to interact with colleagues, I would always tell them that it is in vain if you practice medical laboratory scientists, especially as an hematologist, and you don't have the skills to read film. You don't have the skills to read peripheral blood film. Yesterday we had a lot of lectures. The keynote speaker said, your ability, the skills you acquire to read film makes you a medical laboratory scientist. That being said, I have a very short outline to run with us. I have a very short outline to run with us. We'll be looking about the introduction, the history, standard operating procedures, which is the SOP for bone marrow film reading, microscopic examination of bone marrow films, clinical importance of bone marrow film reading. Then we'll conclude. But the question is, I want to challenge us this morning. How many of us in our various centers are actually ready to carry out this bone marrow film reading? We do not have the opportunities. Not just because we do not have the opportunities, but the question is, are we ready to flow in that direction? If you are being charged with this responsibility, are you ready to carry it out? The question in our minds, I will tell you, with all due respect, is no. Because even the film, the peripheral blood film, we are running away from it. Not to talk of the bone marrow aspect of film reading. So you are not a medical laboratory scientist, hematologist yet, until you acquire the skills of film reading, because it does a lot of work. We agree that in Nigeria we are in a resource-limited country. We are a resource-limited country. So when somebody falls sick, after running PCV or HB, they look at the blood film and they conclude this is anemia. But meanwhile, in the right clinical setting, you cannot just conclude or rule out or rule in or whatsoever that this particular patient has anemia without going down to run some specific investigations. You can't conclude that a patient has cancer, leukemia, any blood cancer without looking at this bone marrow film, because that is the origin of where these things come from. So you must get down to the origin and see that these things are there before you conclude. Now, to tell us about introduction, we will just flow together. To tell us about introduction, bone marrow examination is a crucial diagnostic tool in hematology. When we say crucial diagnostic tool, it provides valuable information about blood cell production, which Dr. Emmanuel Onua dealt with yesterday. It talks about maturation and overall bone marrow health. So if this is about blood production, if this is about blood maturation, if this is about blood cell production and every other thing, it means that it is very important before we draw conclusions on anything we want to do. Bone marrow film reading, which involves analyzing a stained smear of bone marrow aspirate under a microscope, it plays an important role, a pivotal role in diagnosing various blood disorders, including anemia, leukemias, and lymphomas. Next slide. Following standard operating procedure, which is the main reason why we are bringing up this topic, it ensures consistency, accuracy, and reliability. It means that even in our various houses, before you cook a particular meal, you must know what to add and how to add and get your results, isn't it? So if that is that, it means that following standard operating procedures ensures consistency, accuracy, reliability of the bone marrow film, ultimately leading to better patient care. So as a medical laboratory scientist, it is important for you to get the SOPs and understand it so you can give a better patient care. The history of this started far back in 1905, getting down to 1922, 1945, 1909, and finally in 1927, where this was done. The next slide. Bone marrow is a spongy tissue found in the hollow center of certain bones, such as the hip and thigh bones, and it is the manufacturing site of blood cells. Primary and basic hematology will tell us about this. This examination is pivotal for diagnosing various types of hematological blood disorders, including anemia, leukemia, like I said before. The types of bone marrow, we have the bone marrow examination, which involves bone marrow aspiration and bone marrow biopsy. These can be done separately or together depending on the diagnostic needs. Ladies and gentlemen, after the hematology conference we had last month in Bayelsa here, we drew a conclusion that a workshop that has to do with only bone marrow and film reading will be organized by the society. The reason is a lot of people raise concern and discover that in our centers people run away from film reading, and therefore if they run away from the peripheral blood film reading, it means that the bone marrow will be something they will never go close to. And this is our duty. It is our job. We need to carry it on our shoulder. We need to have it like the collar of the clothes we are putting on and get used to it. So let's charge ourselves with the responsibilities that this is what we ought to do. In 2015, 2016, thereabouts, a workshop like this was organized somewhere in Ibadan where we did hands-on. And that was where I picked interest about bone marrow film reading. And since then, I have been running on it. The speed is there, but where is the speed taking me to? Because the center where I'm practicing, we have not actually embraced this practice. So thank you, Federal University of Otuoke, for this dream and to bring this to the fore, as important as it is for we to begin to carry out this aspect of medical laboratory practice. We have bone marrow aspiration, which I mentioned earlier, and bone marrow biopsy. Why bone marrow examination? Why bone marrow examination? Please, brother, you will run with me. Why bone marrow examination? Diagnosing and staging of hematological cancers such as leukemia, lymphoma, and multiple myeloma. We have to evaluating the cause of anemia or thrombocytopenia low platelet count not explained by other tests. Yesterday we got so many revelation while the keynote speaker was on. While he was teaching us, I got a lot from him. Things we cannot ordinarily diagnose when it comes to the peripheral blood film. Bone marrow film reading will reveal that to us. Diagnosing febrile neutropenia, fever with low neutrophil counts to rule out what? Infection. Checking for metastasis in cases of known cancer to assess if the cancer has spread to the bone marrow, and finally to monitor response to treatment in hematological disorder and adjusting therapy accordingly. So this is one way you have to carry out your findings, how to do it, and the results of what you have done. So it is always in 3 stages when we talk about reliability, accuracy. Indications for bone marrow examination. Indications for bone marrow examination: explained anemia, cytopenia or cytosis, abnormal peripheral blood smear morphology, diagnosis, staging, and follow-up of hematological malignancies, acute and chronic leukemias, myelodysplastic syndrome, chronic myeloproliferative disorder, lymphomas, plasma cell myeloma. These are various diseases that may be sounding, they may not be strange to our hearing, but then our practice has not enhanced us to get these things done as it may be. Standard operating procedure, this is where we are now. In standard operating procedure, we have the collection of the sample, which is exclusively done in the ward. Hello, are we together? The collection of bone marrow sample, which is exclusively done at the bedside. Some of us, we have been so privileged to see how it is done. Some of us, we have not been so privileged. So today, by this presentation, I want to task every one of us to ensure that in our various centers, we push for the analysis of bone marrow film reading. If we don't do it, the doctors will not know that we exist. We have to prove to them that these are things we can do. You apply for them. In our various centers, there are investigations that ordinarily you are not carrying out. But if you have proficiency in that area, you can write to your management and ensure that that same parameter or that particular parameter is being done. It is achievable. It is not just rhetorics. It is things we know we can achieve. We have the smear preparation, which is equally done, or which is done in the lab. This is where you put in your proficiency and get a good smear to ensure your result is what? Reliable. We have the staining technique, and we also have the storage. A lot of us in our centers, we do our blood smear for peripheral blood film reading, and after that we discard the slide. I bet you, as easy, as small, as whatsoever you can think that this is, I have a slide box to myself. If you come to my office, I have a little library beside my table where I keep my slides. So when you are looking for a particular slide, I can quickly go there. I have the numbers in my shelf, the same numbers, I have them in the box. So whatever you are looking for, I just go there and pick that particular slide for you. But unfortunately, because we are not doing bone marrow film reading in our centers, it has not been pushed. Such slides will not be seen in my private box. But I want to charge every one of us from today. We are hearing this gospel to change us, and we believe this gospel will change us indeed, and we will begin to practice and be efficient in this aspect of our practice. Bone marrow collection. Because of time, allow me to just flip through the process of collection. It is too lengthy, but the organizers will get the slide across to every one of us I will see the process of collection. So let's look at the smear preparation, which is the basic and second step of what we are to do. Labeling the slides. Slides are labeled with the patient's name, dates, and other relevant information. Of course, we know that this is part of the preparatory stage to ensure that we match every slide to a patient. A patient has an identity, and the sample represents the patient. So we must give these informations to ensure that we match every slide to the patient. Preparing the bone marrow sample. The bone marrow sample is mixed with a small amount of sterile saline solution to create a suspension. Dropping a sample onto the slide, a small drop of the bone marrow suspension is placed onto the slide. Spreading the sample. This process is not different from the whole blood method we use for our thin film. Fixing the sample is fixed with a fixative such as methanol or acetone to preserve the cells. Next slide. The sample is stained with Romanowski stains such as the right stain or Jimshire to enhance the morphology of the cells. The slide is allowed to air dry and is then mounted with a cover slip. The slide is examined under a microscope by a hematologist or a laboratory technician to evaluate the bone marrow cells. Next. Now, this is also the staining procedure. The step 1, you place the bone marrow smear on the slide in a fixative solution, which I have mentioned before. Remove the slide from the fixative and place it in a staining solution for 10 to 15 minutes, then stain the cell and enhance their morphology. Rinse the slide gently with distilled water to remove excess staining. Counter staining. Place the slide in a container solution, e.g. eosine. Please. Thank you. For 1 to 2 minutes to highlight specific cellular structure, rinsing and drying, you rinse the slide gently with distilled water and allow it to air dry. The mounting, you mount slide with a cover slip using a mounting medium DPS. Examine the stained slide under a microscope to evaluate bone marrow cell morphology and diagnose blood disorder. Next slide. On the aspect of storage, label the bone marrow sample container with the patient name, date as usual. Store the bone marrow sample at the appropriate temperature of 20 to 25 degrees for short-term storage and up to 24 hours. You refrigerate for short-term storage up to 7 days. The freezer should be -20 or -80 for long-term storage. Storage medium. Store the bone marrow sample in an appropriate storage medium such as a perennial saline solution and the rest of them. The next slide. Container selection. Use a sterile leak-proof container that is appropriate for storage temperature and medium. Documentation, which is also very important. Like I said earlier, in my own slide box, I have all the numbers to every slide I have in the box. I also have it in my drawer where once you open, you flip through the pages, you will see how it has written. I also have a space where if peradventure I removed a particular slide for a particular disease condition, I will also go back to that page to ensure that I tick that slide has been moved from that position. So if the slide doesn't come back to the box, I can as well look for the same disease condition to replace because they have to be replaced. So documentation is very, very important. We also have, of course, as a medical laboratory scientist, whatever you do, you must have what? Quality control. So you perform regular quality control checks to ensure the sample remains viable and suitable for testing or transplantation. So we have preparation prior to the procedure. The procedure should be explained in detail to the patient. Of course, even in a pre-analytical process in the laboratory, before you collect a sample from a patient, whether for blood group, for genotype, or as simple as malaria test, you have to do what? Explain to the patient that this is what you want to do, how you want to do it, to ensure you get a reliable result. The past clinical history of the patient should be obtained. Now, this takes me down to what the keynote speaker was telling us yesterday about a breast cancer, about a particular, I think, parasite that was found that the patient was sick of, and suddenly it was a process. They used a particular process and discovered that it wasn't a cancer, it was what? Wuchereria bankruptcy. So as a medical laboratory scientist, for you to even get this done, or for you to even start this process, you must ensure the previous history of that patient is known. A blood count and smell should also be obtained. Adequate sedation and analgesia are maintained. Assessment of thrombocytopenia or coagulation, coagulopathic risk. Consider site for PM examination carefully. Now, we understand the challenges we have with the doctors and the pathologists when it comes to this area, but that does not stop us from knowing what it should be and what should be our own rights. Even in the blood bank these days, they come to the blood bank and challenge medical laboratory scientists that they want to take calls, they want to do this, they want to do that. So we should know our own rights. Next slide. The procedure, please, let's leave this out. We'll get it. We have other importance. Now, the bone marrow film, the method. Deliver single drops of aspirate on 2 slides about 1 cm from one end, and then quickly remove most of the blood with a pipette applied to the edge of each drop. Alternatively, place the slide on a slope to allow blood to drain away. The irregularly shaped marrow fragment tends to adhere to the slide, and most of them will be left behind. Next slide. Prepare film using 3 to 4 of a glass slide of the marrow fragments and the remaining blood using a smooth edge glass spreader of not more than 2 cm in width. The marrow fragments are dragged behind the spreader and leave a tail of cells behind them. Now, the thing is, while I was in year 2, I started learning how to make a thin film. And then while we are on laboratory posting in the then UPTH, immediately you get into hematology lab. That is the first thing you will be exposed to. And it baffles me today that we have a lot of our junior colleagues that they find it very difficult to make a smear for thin blood film. That is where your journey as a medical laboratory scientist starts. It is not whether you're a chemical pathologist or you are a histologist or you're whatsoever. That is where your journey starts from. Hello? So it is very important. It is in these cellular trails that the differential counts be made commencing from the marrow fragments and walking back towards the head of the film in this way. Smaller number of cells from the peripheral blood becomes incorporated in the differential count. The preparation can be considered satisfactory only when marrow particles as well as free marrow cells can be seen in stained what? Film. Can we go to the next slide? Fix the film of bone marrow and stain them with Romano whiskey. We've talked this previously, so just give me the next slide. This is typically how it is. Your slide showing how you label it with the patient's information or with the number you have generated in the lab. Film of aspirated bone marrow. The marrow particles are easily visible, mostly at the tail of the film. Those of us that are very familiar with the thin blood film, we know that this is how it is. You appreciate your smear, your slide, your cells, whatever you are looking for at the tail of the film. Next slide. Go to the next slide. Go to the next slide. Examination and assessment of stained blood film. The first thing to do is to look with the naked eyes. Of course, before, even in the thin film, you have to observe the slides physically that you want to view. The particles should then be examined with a low power objective with particular reference to their cellularity, an estimate of whether the bone marrow is hypoplastic or hyperplastic or hypoplastic, sorry for that, nomoplastic or nomocellular, hyperplastic or hypercellular. The next slide. Cellularity of the bone marrow. It is expressed as a ratio of the volume of hemopoietic cells to the total volume of marrow. It is judged by comparing the area occupied by fat space and by nucleated cells in the particles. These histories will be best appreciated if we have the slides on the microscope. What was done then in Ibadan, we have different groups where 4 to 5 members, they have one microscope. Of course, because of the number of persons that attended the workshop, the microscopes may not be enough, and also the slides, the external quality control slides or the proficiency slides they gave to us were not enough, but they ensure that at least 3 to 4 persons to one microscope and to a slide where you have the time to view and the instructor explain to us what we are viewing for better understanding. For example, in an individual 50 years of age, you have the vertebrae 75%, the sternum 60%, and the iliac crest 50%. The next slide. If the percentage is increased for the age of the patient, the marrow is said to be hypercellular or hyperplastic. Such hypercellular marrow is seen in myeloproliferative disorder, e.g. of CML or polycythemia. Lymphoproliferative disorder for ALL or CAL, then infections and acute leukemia. Now, I was also talking to some of our colleagues that each time you mount even a thin blood film that you want to view, while you are looking at the cells, what should be in your mind is the diagnostic features and also what this is interpreting for what a better patient's care. Next slide. Next slide. So this is exactly an example of what you see as the hypercellular marrow and the aplastic marrow. Next slide. Just take us to the next slide because of time. Let's go to, please just go. Okay. So, reading of bone marrow film is for microscopic examination, the technique for effective examination under microscope. So these are the things you should have in you. Tips to identify different cell types, common abnormalities and their significance, and how to accurately report your findings. This can be done when we have a hands-on. The next slide. For the microscopic examination of bone marrow, a systemic approach is crucial for thorough evaluation. The key components are the cellularity pattern, the myeloid lineage, the lymphoid lineage, and the megakaryocytes, which Dr. Emma yesterday took time to explain how these are developed. Clinical importance of bone marrow film reading. Bone marrow film reading provides valuable information for the diagnosis of various blood disorders ranging from anemia, leukemias, lymphomas, myeloproliferative neoplasm, myelodysplastic syndrome, infections, and bone marrow involvement in other diseases like autoimmune disease. So bone marrow film reading is one area that every medical laboratory scientist is supposed to know, to do, and know how to do it better. Next, in conclusion, SOPs ensure consistent and accurate bone marrow film reading. Bone marrow film are a powerful tool for diagnosing blood disorder. Accurate diagnostic leads to timely and appropriate treatments. Thank you for this time.
All right, thank you very much. That was a wonderful presentation and a wonderful way of telling him thank you. You didn't wait for me to ask you to clap better. All right, so we are making progress, and we trust that few times from here we'll be done with today. Two topics already presented. So for those who are joining us, you know what that means. All right, our next presentation shall be on unveiling diagnostic significance of stool microscopy. I know when the presenter was on, some people will be saying, let the microbiologist breathe, or the chemical biologist breathe. All right, it's time to hear from the microbiologists themselves. And to do justice to this presentation is no other person. He is a Deputy Director of Medical Laboratory Service, Federal Medical Center in Egua. He is also pursuing his PhD degree at University of Madonna. He is currently the head of Department Medical Microbiology, Federal Medical Center in Egua. Of course, people like us have trained under him. You know, sometimes they train and they will forget those they train. When we have opportunity like this, we still remind them they trained us. All right, so I have the singular honor, by the permission of my chairman, to make welcome our third presenter for today, MLS Akoba O. Augustine. Please, let's make welcome with a round of applause. Thank you very much. I know it's going to be a scintillating moment because he's an expert himself.
Good morning, everybody. Let me appreciate everybody here this morning. Before then, let me say that I want to stand on the already established protocols already, since two speakers have spoken. I said, my name is Ahoba Augustine from the Federal Medical Center in Egua, and I will be presenting on this unveiling diagnostic significance of stool microscopy. This morning, as I just finished getting ready to come out, my little daughter asked, Daddy, what are your plans for today? I just tried to make her understand that I have a 10-minute presentation in FU Otuoke. Poor little girl asked me, on what? I said, it's going to be on stool. She said, stool? I said, yes. He said, you mean this poo? I said, yes, it's poo. It's stool. He said, you mean you went to the university to study stool? Poo? Let me use that, the word she used exactly. I said, yes, I went to study stool and even walk on stool. The poor girl laughed and ran outside. I said, there's no problem. You are just growing and you see a lot as you grow. Welcome, ladies and gentlemen. A slide, please. Yes. Stool microscopy is a diagnostic tool for identifying protozoans, helminths, and fecal leukocytes. It plays an important role in the diagnosis of gastrointestinal diseases, as it provides a rapid indication of the cause of infection stroke infestation, thereby allowing prompt treatment. Let us know very well that when you are doing stool microscopy, it is very important that your stool be very fresh. It really produce stool and ensure that the stool is not contaminated by any means, either from any body secretions or even urine. Next slide, please. The composition of stool is about 75% water and 25% liquid, undigested food, intestinal secretions, mucus, bipigment, salt, bacteria, and the likes. These are the composition of stool, actually. We actually be talking about stool microscopy, but if you have been on the bench, for those of us who have been in hospital for a long time, you will know that it is practically impossible to talk about stool microscopy without saying one or two things about stool microscopy. I don't know if you have seen this flow very well. If you do, you discover that the flow, we talked about the stool microscopy, of course, and the stool microscopy. Of course, under the stool microscopy, we'll be talking about the consistency, the color, and the, what am I saying? And the composition, and other compositions of feed. Well, under the microscopy, of course, there are various ways of going about the microscopy. The iodine method is there, the direct saline method is there, and sometimes there's a need to stain the slide. For example, if you want to preserve some of these slides for reference purposes and for probably teaching the junior ones coming. We'll talk about this as we progress. Next slide, please. Of course. This is a gross examination of the stool, which is the macroscopic procedure. Observing the physical characteristics of fresh stool sample can help identify the possible organisms present in stool samples. Stool should be examined macroscopically, that is the gross outlook, and evaluated based on criteria such as the consistency, as I said earlier, the color, the quantity, odor, and the presence of mucus. As I said earlier also, these are also diagnostic tools for stool. That is why we cannot separate it from stool microscopy. Yes, please, can you just play this? Okay. Under the stool microscopy, of course, we'll be talking about the consistency, color, quantity, odor, and mucus or blood. Under the consistency, we'll be talking about how loose and how of the stool is, watery stools as in seen in diarrhea, dry and hard stool are seen in constipation, and the pasty stools are due to sometimes high fat content, which are commonly seen in bile duct obstruction, celiac disease, and sometimes you have the ribbon stools, which are seen in plastic bowels. Then the stool color sometimes are supposed to be the normal stool color is actually, please just pause it a little there. Just pause it there. Sometimes the normal color for stool is actually as a result of stechobilinogen in the stool. But in other cases, where you see the variations in the color, is actually as a result of probably some underlying challenges. For example, if the color is about yellow or green, it's mostly indicative of diarrhea. Then if it's black and tarry stool, most times the indication there is that of bleeding from the upper GIT. Progress, please. Okay. When the color of the stool is reddish, most times it's also a result of blood, as it is in the lower GIT. In case of hemorrhoid, fissure or inflammatory processes. If the color is clay color, hold it please. If the color is clay color, if the color is that of clay, most times it's as a result of biliary obstruction. And if it is pale, if the stool is pale or greasy in appearance, it's also most times is when you have some pancreatic deficiencies, which as a result, which sometimes is because of malabsorption. Please, next slide. Microscopic examination of stool proper. To examine fecal specimen, of course, the lens of choice is ×10 and ×40 objectives of the light microscope. And as I said, we cannot talk about microscopy without, okay, we have past that. The method of the preparation of stool microscopy include the wet mount preparation, the concentration method, and the permanent stained smear. Next slide, please. The wet mount actually involve using saline, and you can also use iodine depending on whether you want to demonstrate the cell wall or other body inclusions. A small amount of stool sample is picked with the aid of a wooden applicator and placed on the glass slide, mixed with normal saline to make a thin emulsion and cover with cover slip. This is just the process of making it. We may not spend too much time here. Then for the iodine preparation, ground iodine is used, and of course it is used to demonstrate the chromatin granules and glycogen vacuoles in the stool. Let us also note that iodine kills parasites in the stool. So ordinarily, if you want to demonstrate motility, as maybe you want to look for trophozoid, iodine may not come into play. You will do the saline method directly. Next slide, please. Okay. If you have done your preparations very well, this is what you see. Look at the saline wet mount, and this is the iodine. The one by your right is the iodine wet mount preparations. Next slide. The concentration method is mostly employed when you suspect that the stool may not contain enough parasites for you to see under the wet mount. If you think the number of parasites as too few, you do a concentration method. Next slide, please. The concentration method are the floating technique. Next slide, please. Let's not spend too much time here. We also have the salt floating technique. Next slide. Okay, this is a demonstration of what we see practically in the laboratory. What this guy is doing is a flotation method where your stool is dissolved in appropriate solutions and a glass slide is placed on top of the entire, or at the brim. Then after about 20 to 40 minutes, the glass slide is removed and placed under the microscope. Next slide, please. Then you also have the zinc surface centrifugal flotation technique. This is about like the opposite of the flotation technique. Say so because in the flotation, in the first one, what you do, you use a solution of a very high specific gravity, which means the parasites in the stool will float. But in case of the zinc sulfate, specific gravity is very high. It makes the parasite, of course, sediment while the zinc is on top. And it is the sediment you use for your preparations. Next slide, please. Next slide. Okay, this is the sedimentation technique we have talked about. Okay, move. Formaldehyde concentration, move. Okay, at the end for the zinc sulfate flotation method, this is what you see when you have carried it out properly. The ether layer, you see the ether layer, you see the ether fecal layer, you see the formalin layer, and of course the sediment which you are interested in at this point. Next slide, please. Sometimes too, as I said, the third method is the permanent stain smear. For example, as I said, if you want to keep it for training, the junior ones, most times they are stained. Trichome staining allows visualization of protozoa, yeast, and human cells. Sometimes you do the acid fasting, which allows for visualization of cryptosporidium and others. Optical brightening allows visualization of microsporidium by distinguishing organism structure from the background material. Sometimes the oramine is also employed, which of course takes care of the DNA. Next slide, please. This is the microscopy proper. We'll be under this short video, we'll be seeing different slides. Please, can you start the play? Good. What after your normal preparation, and you now put it under the microscope? Of course, what you'll be, hold it there, please. What you'll be looking out for are leukocytes, red blood cells, macrophages, fats, ova, cysts, and other microorganisms. I like it, good. The presence of leukocytes. Normal stool may contain occasionally 0 to 1 white blood cells. You need to look for white blood cells. The smell must be prepared from the area of mucus or from watery stool. We can also see the red blood cells and white blood cells in wet mouth here. Progress, please. This one is still running, please. Allow it to run. Increased number of the BCs in stool is associated with bacillary dysentery, chronic ulcerative colitis, shigellosis, also known as bacillary dysentery, the salmonella infection, invasive E. coli diarrhea, and fistula of the anus or rectum, and other localized abscesses. Viral and parasitic infection, of course, don't cause white blood cells in the stool. Presence of red blood cells. Bright and red blood cells that indicates bleeding in the lower GIT. You have also black and tarry blood, bleeding from the upper GIT this bleeding, please hold this. We discovered that, please go back a little. Where I was driving to before he gets there, bleeding from the upper GIT. Normally you don't see it in the stool. What you observe is a tarry black, what looks like a blackening in stool. That is why it is actually called occult blood. You don't see it. But if it is bleeding within the lower part of the GIT, you see you can see red blood cells in the stool. Okay. It was after here. Okay. With the presence of red blood cells in stool, as we have said earlier, is a result of bleeding in the lower GIT. Also, of course, I said, okay, this was where we got to before, bleeding from the upper GIT also. Okay, let us progress. Presence of red blood cells. Causes of blood in stool may be due to hemorrhoid, GIT tract malignancy. Presence of macrophages and epithelial cells, inflammation of the bowels. That is what will make you see epithelial cells in your stool because there is inflammation of the bowels. Can we progress? Presence of macrophages sometimes occurs in bacillary dysentery or ulcerative colitis. Sometimes you can also see fats in stool. Majorly it's as a result of malabsorption, deficiency of pancreatic digestive enzymes, deficiency of bile, and also you can also see fiber. Their presence also their presence also shows defect in digestion. Increased amount of meat fiber are also found. In cases of malabsorption syndrome, pancreatic functional defects like cystic fibrosis. Presence of ova and parasites. Normally, there are no parasites or eggs in stool sample under normal situations. Multiple stool samples when doing stool microscopy should be taken into consideration if you want to really get good results. Please hold it there. Normally, it is expected that you do a consecutive 3 days analysis of stool microscopy before you can say somebody has someone does not, before you can rule out. But most times in our hospitals, what we discover is that once a doctor requests stool microscopy, what you get is that he just brings stool, a one-time stool, and you examine it, and if there is no parasite, if you cannot see any parasite, you just rule it out. But it is advised that a patient is entitled to come with stool for 3 consecutive days. The first day is examined. If there's nothing, you examine the second day and the third day. It's only when you have done that and you didn't see anything before you can now rule out parasites, that the person does not have any kind of parasite infestation in him. Then commonly found cysts. Commonly found over cysts and trophozoites are progressive. The protozoan, under intermediate you have the trophozoite. It measures about 12 to 16 micron, as asymmetric, shows purposeful directional motility. Just that you cannot see it clearly on this slide. The trophozoite, it measures about 12 to 60 micron, asymmetric, shows purposeful directional motility. It has a single spherical nucleus, a single central chirosome, and a delicate, evenly distributed chromatin. You have the cyst. This is the cyst of histolytica. It's spherical and measures about 10 to 20 micron. It's a mature cyst with 4 nuclei with a compact central located chirosome. The chirosome is very delicate. Just this picture is not clear enough. Otherwise, for me that is close, I can see these descriptions there. Allow it progress, please. The cyst. Some cysts may have chromatode bar. This is the infective stage of the parasite. Under Gardia lambia trophozoite, it measures about 10 to 12 micron and is pear-shaped with tapering end, actively motile like a falling leaf. You can see that. You can see the trophozoite moving there. It has 2 centrally placed nuclei and uniform granular cytoplasm. This is the cyst. It is over to ellipsoid, measuring about 8 to 19 micron parasite. For example, you can see yeast, fungi, which are common in stool. Pollen grains in stool can be mistaken mostly for hermit eggs. These pollen grains, so you have the one by the right. Most times people see this and think that they are actually eggs of hermit, but it is good to know them, and once you know them, you'll be able to differentiate them from actual parasites. Can it flow, please? You can also see plant fiber or plant cell. This is a plant fiber, and the other one by the right is the plant cells. So sometimes you can also see air bubbles. I think we have passed it. Let's go to the next slide, please. Okay. In conclusion, gentlemen, stool microscopy is a valuable diagnostic tool in the detection and management of gastrointestinal infestation and diseases. Its significance lies in a non-invasive, rapid, and cost-effective nature, making it an essential component of modern diagnostic tool in medical laboratory. In conclusion, what will be taken away are, next slide, please. 1, this procedure of stool microscopy is non-invasive, it is rapid, and it is cost-effective. On this note, let me thank you with the next slide. God bless you.
think you can do better than that? That was a wonderful one. I told you an expert was going to be presenting, and he has just done justice to that presentation. Thank you very much, sir. We hope when we have other time to invite you, also give us the privilege of having your presence. Thank you very much. At this point, we want to recognize the presence of the Dean of Faculty of Basic Medical Science. Sir, you're welcome to be part of us. We are very, very grateful to have you here. And just as the presentation was also going on, we have the registrar's representative, that's council rep, just walked in and is part of us, Mr. Romeo Menini. Thank you very much. We thought you were not going to be coming. You're highly welcome. Thank you. All right, we've had 3 presentations. And some things are itching to ask questions because these things are very interesting. So we will be taking a few questions as time will permit us, so that we would have satisfied our conscience that we didn't forget our questions. So if you have questions, can I have you identified by raising your hands? Yes, number 1, number 2, number 3. All right, let's get to take the questions.
Yeah, thank you very much. Just to react to Loveday's presentation on bone marrow samples. You know, the one thing we should also know, all protocols duly observed. I respect and recognize the dignitaries here, and I speak based on the established protocols. Thank you. So where's Loveday? Has it disappeared? Okay. Yes, I said that your presentation was quite interesting, particularly on the bone marrow aspirate or bone marrow smear. But you know, we as scientists, we have challenge on even collecting the sample or getting the sample. When I was on the bench, you understand, you will wait for several hours to get that sample, and you might not get it that day. So, and I think we have to continuously liaise with our medical colleagues, you understand, the doctors. You know, when they request that, they should also make the sample available. And we also should be able to, with high-level advocacy and interaction and collaboration, we should also know how to collect that, you understand? Because sometimes these young doctors don't, some of them don't know how to collect that, or they run away from that, or it could be based on the instruction by the consultant that don't touch the patient until I tell you, or don't collect anything until I tell you, you understand? I worked on that, and that's a challenge, I mean, we used to experience. So, and we need to note that as a major challenge. And whenever, I'm happy the dean is here, so we need to fashion out how we can always work together as a team. It's for the patient's good. You understand? When we collaborate very well. Thank you. That's that particularly. Let me leave the other one.
Thank you very much for that invaluable contribution. We go to the second question.
Thank you so much for the presentation. I want to talk on these 2 microscopy. Please, I want to please ask, do we report yeast in stool? Microscopy, some people of the idea that it shouldn't be reported. And then also, when we see crystals in stool, sometimes we see crystals, we see calcium oxalates. And then sometimes we see charcoal-laden crystals, but we don't see parasites. Do we report them? And then maybe that would not be, I don't know if the doctors even understand some of these things. So these are problems that we encounter. So I want to know, do we report this and just move on or what? Thank you.
All right, I think, sir, would you like to respond immediately? All right.
Hello, my dear colleague. Actually, we don't report yeast as of importance as if it is important in stool, because almost in all stool you can see yeast. If you take stool from any person here now, just leave it for some time and do a microscope, you may see yeast. They are of no particular importance, except probably when the person is highly immunocompromised. You understand? Yeah. Is that all? Of course, sometimes you can, most times, some of these crystals are seen by when there is a contamination from the urine. You understand? They are actually not from the stool most times. They come from contamination from urine.
Thank you very much. Let's get the third person. Okay, our chief wants to add something.
Sir, I thought when you see a quantum of calcium oxalate there, oxalate crystals, it depicts maybe the patient is on antibiotics, which can guide the clinician to take appropriate decision. And it will also help you. Like in situations where they request for stool examination as well as stool culture. You know, when you see a lot of that, you know that you might not get much from the urine culture. So I think it's a pointer that you can report it. We do report in those days. I don't know of now. Thank you.
All right, thank you very much. Okay.
Good afternoon, everyone. Standing on the already existing protocol, I want to ask our last presenter. He said that before you rule out that a patient is not having any parasite or cyst or any kind of infestation, there must be a 3 times examination of the stool. So as medical laboratory scientists, what are we expected to do in this situation that they brought only one sample for us to examine? Are we to go back to the doctor to tell them of what is expected of them, or we have to discuss with the patient to bring those 3 consecutive samples? What are we expected to do for us to have an accurate and effective diagnosis for the patient?
All right.
Dear colleague, you will agree with me that a lot is wrong with our system, with our healthcare system. And that boils down to this kind of challenge. Just like those of us who are very conversant with reader tests, just go to the laboratory and the blood sample is taken, somebody reports that you have typhoid. Just at one, without even knowing if there is an increase in the titers. If it continues increase in titer, you just report. But you all know that it's supposed to be timed. If, for example, you do a weather test today and, for example, I'm just giving an empirical figure, is 80. By the time you do it, by about 2 or 3 days time, she will have risen by that. That's when you establish that the person has typhoid. But who does it? Many people don't do it. That is why that is the challenge we have in our system. Also, what I have just told you is the normal situation. So then it depends on your facility. For me, in my facility, we just use one, but this is the ideal. Of course, if we want to go further, we can. If we want to do what is really right, we can go further to educating the doctor. The doctor may not even know that you need more than 1 sample for this. But if we educate them and they still, for example, you give them a result that this person does not have have parasite in him, in her stool or his stool, and maybe the clinician thinks that there's still something wrong. But by the time you come to tell him, please, just 1 is not enough. We need about 2 or 3, and maybe at the 3rd run or the 2nd run, you say something. I can assure you that he days.
Thank you very much. Okay, the next question.
Thank you very much. Standing on the existing protocol, mine is not much a question, but it's like an observation. We have a lot of stool parasites, but I'm practicing, and I've several times come to find out that you rarely see them these days. I'm just talking so that in this forum, if I am wrong, maybe they will tell me if there is somebody that is seeing it regularly, so that I will know where the problem is coming from. These days, you hardly see parasites in the stool. It's always no ova or cyst or parasite seen. And I have interest in microbiology, and I think I do it very well. So most of the times I do concentration methods, I still don't see anything. So I don't know, is it a common thing?
Okay, the presenter want to say something first before any other person.
Thank you, madam. You are very correct. It is not peculiar to you or probably your facility. It is same everywhere. And I think I've read articles on this subject. The simple reason is because of the awareness. Hygiene has been improved so much. But if you still go into the villages where hygiene is still poor, you will observe what you just spoke about. But in these areas where the water seems to be clean and the people seems to wash their hands and wash their leaves and their food products very well, you can hardly see stool. So we are very much in order for reporting no parasites seen if you really did not see any.
Thank you very much. Oh, Doc has something to say.
To support him, I found out that on regular basis, people go on this worm medicine. On average, people take it every 3 months. Every layman just, I took worm medicine 3 months ago, you know. There's constant use of worm medicine, and that has also helped to reduce the infection.
All right, thank you very much. Okay, the last comment before we take the next question.
Okay, thank you. I also want to contribute that the patients also, some of them don't bring fresh stool. That's another reason that could be the cause of that, because sometimes when we get fresh stool, we may also see it. And also the prevalence in unclean environments too.
Okay, thank you very much for all the contributions. Let's get the last question, I suppose. Okay, answers.
Okay, I have, apart from question, I want to advocate, because we have been talking about film reading. When the Loveday, scientist Loveday was saying, talking about film, making of film. I think that is the basic things. I say it's 200 level, that is why I start practicing film, doing the film. And if we don't get the right film, we cannot be able to get the right interpretation. So I'm actually suggesting for those that in academics, do we start introducing making of film to our students in 200 level. That is a second semester when you talk about introduction to MLS. Let them start practicing it, because practice make what? Perfect. That is my own contribution in that area. And the question I want to ask our guy for these two, in as much now I'm interested in artificial intelligence. We talk about all those parasites. Is there any way we can preserve them for us to get them as a database? So when we want to develop artificial intelligence in all those reading of stool and everything, we'll be able to get a data that we can upload and train them. So it is very easy to differentiate between the artifact, you talk about the artifact and the normal this thing. Is there any way we can preserve them? And then, if there's any way, I'd be interested to have them, because I want to develop more and probably develop a model which you can come and get from me. I will license it before you get it. You pay for it.
Wow, that's a wonderful one. So I think you have something to say. All right.
I wouldn't know what to mean by that preservation, except that I know that in stool, if for example a stool sample comes into your laboratory and you do a microscopy and you find parasites in them, we know you can preserve the stool. I know, that's what I know. You can preserve the stool, and from there continue to make extra, more films or smears for the younger ones, junior ones coming. But on slide, I don't have information about that, except for the stained ones.
Well, I think under the microscope we can get a micrograph of that slide, and then you can use it for a model.
You can preserve the parasites, like if you have any of this worm, maybe on the wet trap, you can preserve it. Yes, sir. You can use fixative. Yes. I mean, formaldehyde, simple formaldehyde can do that. Or formaldehyde, or formaldehyde, yes. So what? Yeah, depending on how long you want to preserve it. Is it not for a short while? If you go to the labs, research labs, you see them there. They are preserved. And you use fixatives. And we have histologists here. They can tell us how long we can preserve them. That's why we're here. It's an academic environment. Thank you.
Well, they have spoken. Yes, like what I was saying, if the parasite is viewed under the microscope, you can take a micrograph of that field, and it becomes a picture you can use for your modeling. So it's outside preserving the stool. From the microscope, the slide under the microscope, you can get a micrograph. Then you can get the model from there. I think that is possible. Okay, the last one. While we get ready for the next presentation.
Thank you so much. Standing on the existing protocol, I just have one question to ask. Are fats of clinical importance in stool microscopy? Yes, fats.
Okay, whether if fat cells are of clinical importance when you talk about stool microscopy.
Yes, a little. They are important because they are seen most times in cases of malabsorption. If there's no proper absorption in the intestine, of course you can see fats. I think I said it when I was making my presentation.
All right, thank you very much for all the questions, the contributions, the answers that has made this session a robust and powerful one. Okay, we'll be driving forward as we get set for the next presentation. I want to be sure our resource person is on ground. Okay, thank you very much. All right, so we'll be expecting to hear from our resource person who will be doing a presentation on exploring the microcosm of urine microscopy for diagnostic utility and research. And our resource person is no other person than the head of department Chemical Pathology and Molecular Diagnostics, Faculty of Medical Laboratory Science, Federal University of Otuoke Bayelsa State, Dr. John Ifeonkwe. Please, with a round of applause, let's make welcome our next presenter for today.
Good day, my dear colleagues. Without wasting time, we'll talk about something that is usually neglected in the diagnostic world. When our keynote speaker was making his presentation yesterday, he mentioned the areas where microscopic examination is applied. He mentioned microbiology, hematology, histopathology. He failed to mention chemical pathology because we appear to be neglected in this area. One of my colleagues asked me some time ago, what do you people need microscope for in chemical pathology? after today, you will know that the chemical pathologist needs a microscope. And if you're a chemical pathologist, you don't have a microscope, you are incomplete. Exploring the microcosm of urine microscopy for diagnostic utility and research. Microcosm, small, mighty. If you go to church, just as I do, you must have heard in the Bible that at a point, Jesus stood by the offering box and looked at all that was given in the temple. And after his observation, he said, this woman that did cast the least of all offerings, what she gave is the highest. So, though this looks small, after going through it today, you understand how important it is in diagnostics and as well in research. Urine, we all know what urine is. I'm not sure there's anybody here that has not passed urine today. Is there anybody? If you have not passed urine today, that means something is wrong. We all know what urine is, and we have seen it today. Next slide, please. Yes, we'll look at routine microscopic examination of urine. We will be able, at the end of this, identify different microscopic elements in urine. Then we'll be able to correlate these microscopic elements seen in urine with possible clinical conditions. And at the end of the day, we'll be able to understand that urine can be therapeutic and also poisonous. Let me take on that. We've had stories of people that drink urine for therapeutic purposes. When we finish this, you will understand why they do what they do. If I don't say it, please remind me. Next slide. Yes, urine collection. Sometimes we need to prepare the patient, or we don't need to prepare the patient depending on what type of sample that we need. Sometimes we do 24 hours urine collection. The urine can be collected randomly. It can be collected from a catheter. After collection, there's need to send the urine to the lab immediately. One of the problems we have in diagnostics in this part of the world is pre-analytical stage of our analysis. When you get this stage wrong, whatever you do, you are only wasting your time. And we have seen in different instances that people that send samples to us in the laboratory, they miss it at this stage. And when they miss it at this stage, whatever we do to give the right result, we are only wasting our time. Sometimes somebody can collect a sample, keep it in his or her car under the hot sun, 1 hour, 2 hours, 3 hours, 6 hours. At the end of the day, he brings it to you in the laboratory. That sample is no longer fit for you to do anything good. So after collection, there should be rapid transportation of the sample to the laboratory. The sample can be stored at room temperature before examination, or it can be refrigerated. It's better to examine your sample within 30 minutes of collection. Next slide. The sample for analysis must be well mixed, so that everything in the sample can be together. Then the recommended volume for analysis is 10 to 15 mils. Most times we use 12 mils for routine analysis. Next. We use a tube to collect the urine sample. placed in a centrifuge at a speed of 1,200 revolutions per minute. This is the optimal speed for urine separation. If you use a very high speed, it will destroy some of the particles, some of the microscopic elements that you need to observe. So you use this speed, 1,200 revolutions per minute. ICT, I'm not sure I'm having the right slide. 2. Okay. Next. All right. So after centrifugation, you decant the urine, pour out, no? You pour out the upper layer of the urine, leaving about 1 ml of urine in the bottom of the test tube. Next slide. Okay, after that, you load the sediment on a glass slide. You can use a pipette, take about 15 microliters of the sample on a slide, then you place a cover slip on it. Now we have commercially available slides that can be used for urine analysis. Just as you are seeing there, that is a commercially available urine microscopy slide. What you need to do is to apply your urine at one of the ends, and the urine goes in through capillary action. So after loading your slide, while loading your slides, you avoid air bubbles and do not overfill your slide. Next. Urine examination. You mount your slide on a microscope. You start with a low power objective times 10 to scan all areas. Then you change to times 40, the high power objective. And you look at a minimum of 10 to 12 representative fields. Elements must be evenly distributed on the slide. If not evenly distributed, then you make another slide. Next. These are some of the microscopic elements that we see in urine. The truth is that some of us see these things in urine, especially those in microbiology, but they don't know what it means. So today, chemical pathology will teach you microscopy. These are bilirubin crystals. They are usually seen in acidic urines. They appear needle-like, granular dark brown crystals. They are often associated with high levels of conjugated bilirubin, and are seen in liver disorders of obstructive nature. What it means is that when you see bilirubin crystals in urine, what it's telling you is that there is a problem with the liver, and that problem in the liver is of obstructive nature. If you do an analysis of the patient's serum, looking at the ALP, you see that the patient will equally have elevated ALP levels. In children with jaundice, this is a very essential tool to differentiate jaundice because of liver damage or neonatal jaundice. If it is as a result of liver damage in the child, when you do a microscopy of the urine, you will see bilirubin crystals in the urine. Next slide. Cholesterol crystals. Cholesterol crystals are usually seen in acidic urine. They are often colorless, refractile, with notched corners. They have step ladder pattern and they are soluble in alcohol. Some of the pictures you are seeing here are from my laboratory, from my digital microscope. When you see a cholesterol crystal, for you to actually know if that is it, since it is soluble in alcohol, you take your spirit, drop it on the slide, wait a little while, observe again. If they disappear, then you confirm that what you've actually seen is this. This is often seen in nephrotic syndrome. What it tells you is that when you see cholesterol in somebody's urine, if you do urine analysis using a strip, you definitely see protein in the urine because it is an indication of a problem in the kidney. The kidney now is not retaining protein. Protein is being leaked out. Next slide. 16. This is from my lab. I actually saw this in a patient 2 years ago. I decided to save it. I never knew that one day like this, I will need it. This patient was complaining of pain, severe pain always. I decided to do urine microscopy, culture, and sensitivity. When I looked at the microscopy, I saw this. These are cysteine crystals. They are seen in genetic disease cystinuria, and it is a common case seen in kidney stone. Cysteine in urine, because of its accumulation, causes kidney stone. The patient went further to do ultrasound, and the ultrasound equally confirmed the kidney stone. And he was able to tell me that his father suffered from the same thing. And as you can see, it's a genetic thing. It's an autosomal recessive disease. So this crystal is soluble, it is monomorphic. It comes in only one shape, hexagonal plates that resemble benzene rings. They are beautiful structures. They are soluble in alkali, especially ammonia. If you drop sodium hydroxide on your slide, you will see that they will disappear. That confirms to you that what you've actually seen is cysteine crystal. Next slide. This is leucine crystal. They are normally seen in either acidic or neutral urine. They are concentric circles with radial striations, yellow-brown in color. They resemble a cross-section of a tree trunk. They look like one of the parasites my dear senior colleague showed to us. They are soluble in alkali, like sodium hydroxide as well. These are seen in liver disorders with impaired amino acid metabolism. That impaired amino acid is leucine. Next slide. Tyrosine crystals. They are seen in acidic and neutral urine. They are yellow or dark colors like needles massed together. You can see how they are massed together. They are always together, not single. They are insoluble in ethanol, insoluble in ether and acetone. So the confirmatory test for you when you see this on the slide is to drop any of these reagents on your slide. If they remain, then you confirm what you've seen is tyrosine crystals. This is usually seen in liver disorders with impaired amino acid metabolism. The amino acid that has impaired metabolism in this case is tyrosine. Next slide. Triple phosphate crystals. Very beautiful. The first day I saw it, I remember what we are always told, that they look like coffin lid. If you have lost someone before, you understand what I'm talking about. So they look like the cover of a coffin or a casket. They are made of magnesium, ammonium, and phosphate. They are seen in patients with struvite stones. They equally cause kidney stones, urinary tract infections, especially with proteus. So if you see this in a patient's sample, it tells you that the patient either has kidney stones or urinary tract infection, and the organism implicated in that case is usually proteus. I bet you if you go ahead to do the culture, you will isolate proteus. Next slide. Epithelial cells. We have cellular components in the urine as well. You know, what marvels me is this. The urine is a filtrate of everything that goes through the body, is it not? From your brain everywhere, it comes out as urine. So many things come out in our urine. So we have cellular components of the urine, like epithelial cells. The upper one is the one we see almost every day when we do some microscopy of high vaginal swab, ECS, contaminated urine, most times. Squamous epithelial cells. If you see the cytoplasm area is large with small nucleus, then you have the transitional epithelial cells with smaller cytoplasm and bigger nucleus than the squamous. Then you have the renal epithelial cells. They have big nucleus with very small cytoplasm. When we get to the next slide, you understand the implication of this. Squamous epithelial cells, they don't have any diagnostic importance. They are just cells wearing away from the upper regions. Next slide. Okay, these are renal tubular epithelial cells. As I said, they have large nucleus with small cytoplasm. They are usually from the renal pelvis, ureter or bladder. They are columnar or oval. They have granular cytoplasm with a single large refractile eccentric nucleus. Pathological significance. They are seen in tubular damage like acute tubular necrosis, pyelonephritis. They are seen in viral infection of the kidney, seen in allograft rejection, and they are equally seen in salicylate or heavy metal poisoning. So our dean should take note of this for his forensic studies. So if you suspect that a patient or one has been poisoned with salicylate, you do microscopy of the urine and see if you can identify this. Or if you do a urine microscopy and you see renal tubular epithelial cells, you can go ahead to investigate if the person took salicylate drug that could have caused the poisoning. Some years back, one of the renowned doctors in this state, Dr. Phenomo, he normally sent urine microscopy to our place. He always say microscopy. One day I asked, so why do you prefer microscopy, not microscopy with culture? He said, there's something I'm looking for. What are you looking for, sir? This is what he's looking for, because before you do your electrolytes, urea and creatinine, at that early stage of kidney damage, when you start seeing this, that is an early sign of a problem in the kidney. So anytime you see this, it's a red flag for the patient concerning impaired kidney. Next slide, please. These are transitional epithelial cells. As I said earlier, they have a smaller cytoplasm than the squamous epithelial cells, and they have larger nucleus than the squamous. They are also known as urothelial cells. They can occur in spherical, polyhedral, and corded forms. They originate from the bladder, ureters, and the renal pelvis, usually seen in urinary tract infection after a patient has been catheterized, and also in transitional cell carcinoma. So when you see this in a patient, these are things that could be going on in the patient. Next slide. Helen casts, colorless and almost invisible under bright field microscope. Smooth texture with low refractive index. They have parallel size with rounded ends. Occasionally they can be granular. They are made of termhophosphor mucoprotein. They are usually seen in acute glomerulonephritis, pyelonephritis, chronic renal disease, congestive heart failure, meningitis, diabetic nephropathy. Just this can be implicated in all these. Next slide. Granular cast, composed of degenerated cellular debris, mainly of renal tubular epithelial cells. So this is an aggregate of the renal tubular epithelial cells that we saw earlier. And we usually see this in acute glomerulonephritis, pyelonephritis, acute tubular necrosis. In acute tubular necrosis, you see them appearing muddy brown. Next slide. Waxy cast. They appear smooth with melted wax appearance. If you have used a candle before, you understand what I'm talking about. These are seen in final stage of cast degeneration, and they indicate tubular injury of a more chronic nature than granular or cellular cast. They are associated with low urine flow. So when the kidney is impaired, low urine flow, and significantly associated with end stage of renal failure. Next stage. So even when you've not done the chemical analysis of a patient's sample, when you see these things in urine, they point to something. Red blood cell casts. They are found when red blood cells are trapped in mucoprotein matrix. Presence of even a single cast. The presence of just one red blood cell cast is very significant. The presence could indicate intrarenal hemorrhage, glomerulonephritis, acute tubular necrosis, or renal ischemia. Next slide. White blood cell casts. They are cylindrical structures, mainly comprising of white blood cells embedded in protein matrix. Most typical of acute pyelonephritis, may be present in glomerulonephritis as well. Next slide, please. Okay, urine microscopy, looking small but actually mighty. Let me go back to what I said. Some people drink urine because of its therapeutic purposes. People that take urine can do so because they want to be immunized. Do you get me? immunization from drinking urine. Why? Urine contains bacteria, virus. So if you are lucky to take it at a low quantity of these organisms, the immunologist here can explain better. Immune reaction, it will trigger immune reaction in the system, so the body can produce immunity against these organisms. That is one. Then because of the different crystals I mentioned contained in the urine, some of these crystals can be therapeutic in their nature. So by drinking urine, these crystals present in the urine can cure one or two things. And urine by itself can be poisonous because some of these components in the urine, they can actually cause problems in the system. The person can get infection, the person can be poisoned by the components in the urine. Though it's a small area often neglected, it is very large, and we must not neglect its application in our day-to-day practice. Thank you.
I think we can do much more better than that. For those of us who are thinking that urine is not important, we have now seen how important urine is now. Thank you very much, dear presenter, for today. All right, so we will be taking an abstract presentation right away before we take another presentation. And for those of us who are presenting abstract, if you're here, please kindly get to me so that I can get your necessary information. However, permit me to bring to the rostrum for presentation of one of the abstracts the head of department, histopathology, cytopathology, Federal College of Veterinary and Medical Laboratory Technology, VOM, all the way from Plateau State. So that's wonderful. He is a PhD student with Ambrose Saleh University, Edo State. And the person I'm talking about is known as PAM. Not this one, no. D. Daliop. I used to like those names from Plateau State because they used to be very, very wonderful. Please, with a round of applause, let's make welcome our able HOD for his abstract presentation. Thank you very much.
Thank you very much, sir. Let me go straight to the point. Then later on, I will appreciate you. Because left me, when I heard about this workshop, I read through my provost. He was the one that extended the invitation to me. I think he saw it under one of the platform and forwarded to me that there is need for me to attend this workshop. So the college decided to sponsor me. So I'm here on behalf of the college, not on my own. Then I now say that if I come, I know definitely I will go back home loaded. But I will not come empty-handed. Let me also give you something, so that my coming here will not be in vain. Let me not be a consumer only, but you also consume from me. So that's why I decided to say, let me just pick one of my work and share with you. So, and I'm presenting this afternoon I done a work on this evaluation of the histomorphology of the cell organs of albino rat exposed to tetrazine fruit additive. Next slide. This is my abstract. Next slide. Next slide. Introduction. What are fruit additives? Fruit additives are natural or synthetic substances used to color fruit, drugs, drink, cosmetics, etc. Next slide. The total world colorant production is estimated to be 8 million tons per year. So this has been known of causing health problems both in adults and children. Next slide. So example of food additives that we consume without knowing, some of them are tetrazine, chocolate brown, blue color, red color, green color. Next slide. So tetrazine dye, it is red to maroon in color, also known as yellow 5. The code number is E102. Then widely, it's widely used in UK, but has been prohibited in Japan, Norway, and USA. Next slide. And this is the effect of tetrazine. You can see some of the effect. It causes some hypersensitivity, allergic reaction, behavioral changes in children, decrease of body weight, blurred vision, migraine, headache, and so on and so forth. Next slide. So the acceptable daily intake, that's ADI of tetrazine. The acceptable intake is, the acceptable daily intake, that's ADI, is the amount of a substance that can be taken every day for an entire lifetime without any adverse effect. And tetrazine has an ADI of up to 7.5 milligrams per kg by body weight, and this has since been reviewed by, that is for children age 2 to 16. Next slide. Let's just go to the toxicity of tetrazine is there. That is the AD50. That one is very important too. Go back. Go back. Okay, please come forward again. Under the next slide. So, based on the literature review, toxicity of tetrazine, that is the acute oral toxicity, was assessed in rodents and in mice. So the LD50 value was determined to be 12,750 milligrams per kg per body weight. And in rats, that is what I use for my work now. And in rats, it was 2,000 milligrams per kg per body weight. Next slide. So these are some of the example of food additives that we consume on the daily basis. This has been listed by Codex Alimentarius since 2010, though it has been reviewed. But I was not able to get the reviewed food additive. These are some of the examples with their uses. Next slide. These are some of the examples. Next. This is the properties of tetrazine. Next. Background of the study. Yes. In recent times, the rate in which individuals are consuming and exposed to food additive has become a subject of concern. So the exponential rise in the use of food additives in drinks, drugs, food, etc. is on the increase on daily basis. As important as food additives are, it has been observed that the excessive use may be associated with adverse effect on the health status of individual. Such additives. Next slide. Okay, recent studies have shown that some of these food additives containing chemical may have serious health implications, including the potential to cause cancer, neurological disorder, and other illnesses, and so on and so forth. Let's go to justification of the study. Justification of this study. Many people, both lay and learned, do not know what food additives, that's coloring agents, are contained in food and drinks they consume on a daily basis. There are some hidden dangers of food additives. Prevention chemicals hidden in the food we eat every day are chemicals that are designed to prevent spoilage and extend shelf life. However, some of these food preservatives and additives are doing more harm than good. Recent studies have revealed that some of these chemicals may have serious health problems, including the potential to cause cancer, neurological disorder, and other illnesses. Previous work have shown an appreciable DNA liver and kidney damage as detected by Comet assay
Next slide. Some of these additives are used to add color to the food to replace the natural dye that was lost during processing the food. So the synthetic food additives consumed undergo metabolic activities in the liver, kidney, stomach, and absorption through the intestine. In view of the vital role of the visceral organs such as the liver, kidney, stomach, small intestine, and pancreas in the body metabolic processes, it is therefore essential to evaluate, examine, and investigate the histomorphological. I extract this work because this is the histological part of the work. Because I did the work, there is a hematological part and there is also a biochemical part of it. So I extract the histological part of it. So that is my area of concern for now. Let's move. General aim of the study. The overall objective of this study is to evaluate the histomorphology of the visceral organs, liver, kidney, stomach, small intestine, and pancreas of albino rat exposed to tetrazine food additive. Next slide. These are the specific objective. To evaluate the effect of tetrazine. So as I said, these are so look at the effect on the liver, on all the organs. Next, move. Please just go to methodology, chapter 3. So I was able to do some literature on all the physiology, anatomy, and histology of all the organs. So materials and method, source of tetrazine and animals. The synthetic food additive, that's tetrazine powder, was processed from Medicom Laboratory Nigeria Limited, Jos, Plateau State, with the following specifications. So this was the specification, the molecular weight is this, product is this, EC number is this. Next line. So materials and method contained. The albino rats were obtained from the Animal House of Federal College of Veterinary and Medical Laboratory Technology and its environs, VOM, Plateau State. So the animals were housed in iron cases at an ambient temperature and relative humidity. The animals were fed with pelletized growers mash produced from ground cereals and oil mills, Zawan, Jos South, Local Government Council, Plateau State, and clean drinking water. The animals were acclimatized for 2 weeks, that's 14 days, before the administration of the food additive. Next line. Study area. This research was conducted at the Histopathology Department of Federal College of Veterinary and Medical Laboratory Technology, VOM, and Central Diagnostic of National Veterinary Research Institute, VOM, all in Plateau State, Nigeria. Experimental design. A total of 25 albino rats were used for this study. The animals were divided into 5 groups of 5 rats, each as group A, B, C, D, and E. Group A was the control, fed only with the feed and water throughout the period of the experiment, while group B, C, D, and E were administered with the test dose of the stock solution of the food additive as 100 milligram per ml, 200 milligram per ml, 400 milligram per ml, and 600 milligram per ml, respectively. So the administration was given according to the body weight of each animal. This can be presented in the calculation below. Next line. So determination of the dosage. So from the dosage, the LD50 value of the rat was the LD50 value of the rat was found to be 2,000 milligram per kg per body weight. So the highest concentration that was used is 600 milligram per ml, and lower concentration is 100 milligram per ml. For more details on the calculation of the dosage and preparation of the stock solution of each group from BC, so we can just see the calculation of all this. Let's move. So preparation, this is the calculation from the stock solution. So determination of the dosage. The treatment was administered to the animals for 42 days, that is 6 weeks. Each rat was weighed before and after the treatment period of the experiment. Next line. So the histological analysis. After the administration of the test dosage, the animals were weighed before they were killed through anesthesia by inhalation of chloroform within a closed chamber. The organs were excised and fixed in 10% buffered formalin until analysis. Tissues were cut in sections ranges from 3 mm to 5 mm of all the organs concerned and were routinely processed for paraffin wax embedding, and sections were prepared using rotary microtome machine and stained with routine hematoxylin and eosin staining technique. Next line. Statistic analysis. So the data obtained were statistically analyzed using statistical package for social sciences version 27 2020. So the least square difference LSD test was used to compare the significant difference between means of treatment. Values are expressed as mean. Let's move. Result, data presentation and discussion. So this is the table that contain, this is the table. This table gives us the group A, that is group A, that is the control, that is body weight after administration, that is column 1, then body weight after administration, then dosage. From this group A, this is control. Then group B, the dosage was 100 milligram per kg per body weight. So you can see body weight before administration and body weight after administration, then dosage. Then after dosage of each group. I think you understand what this topic is talking about. Next. So this now let's the next table. So the next table, this table 4.2 is showing histopathology chart grading the extent of pathological effects on the visceral organs. Next line. So after the work, we were able to look at the tissue. So from this plate A1, this plate A1 is showing, that is because each group has 5 rats, and I number the rat 1, 2, 3. So when you see A1, it means that rat number 1 in group A. So it shows section of liver, no pathology observed. It's the same thing with other organs too. Next. A2 showing section of kidney, no pathology observed, and this is the magnification that we use times 10. Next line. A3 showing section of intestine, no pathology observed here. Next. A4, the same thing. This is pancreas. This is the structure of a section of a pancreas. There's no pathology here. Now, this is plate B, that is group B now, where the administration of tetrazine started. That is from rat number 1, that is B1, showing section of liver with mild necrosis. If you look at up there, that is the central vein. But down here, that is a necrosis, that is the depth of the cell. So you can see it showing mild necrosis of the hepatocyte. Next line, B2, that's rat number 2, also showing section of kidney with congestion of the renal vessel. So next, this one shows section of small intestine. There is no pathology here. Observe here. Then C1, that is group C now. It shows section of liver with severe necrosis of the hepatocyte. That is the yellow arrow. Then the other one, it's showing, that's the congestion of the central vein. That's the black star. Next. Then plate C2 now. It's showing section of kidney with severe necrosis of the glomerular. that's black arrow, and congestion of the renal vessel, that's yellow arrow. Next. Then the small intestine, there's no pathology observed here, using, that is under group C now. Next. So this D1, that's group D. So it's showing section of liver with congestion of the central vein, that's yellow star. Central vein, that is a yellow star. And the portal vein, that is black star. Then necrosis of the hepatocyte, yellow arrows. Next. Next line. So D4 shows section of pancreas with congestion of the pancreatic vessel, black arrow. Next line. Then E1, that is group E now, shows section of liver with necrosis of hepatocyte, that is yellow arrows, and the central vein, black arrow. Then let's move. Then E2, it shows section of kidney with congestion of the renal blood vessel, that's black arrow, and necrosis around the renal vessel, yellow arrow. Yes. So E3 shows section of small intestine, no pathology observed. Next line. Now discussion. In this present study, this is a short-term research with high dosage of the food additives, that's tetrazine. The administration of the food additive lasted 6 weeks, that's 42 days. Next line. Data in table 4.1 reveal the body weight of the animals before and after administration of the additive, dosage stroke milligram, and required dosage stroke volume per body weight per meal from group A to E. Before the administration of the additive, 1 rat died in group E. This may be due to climate change. During the administration of the additive, 2 rats from the control group A died. This may be as a result of environmental condition. Still on the mortality rate, 1 rat died from group C, D, and E. This may be due to the lethal effect of the additive, that's tetrazine. And this is in agreement with the absorption of tetrazine increases mortality rate in rat. That is Mohammed et al. 2019. Next line. Body weights of the animals were taken before and after the administration of the food additive. Results revealed that 99% of the animals show significant increase in body weight. This may be due to the food additive, and this is in line with the I think there's something is mixed up there. Food additive, and this is in line, I missed one line because it's in line with Sexa et al. Because based on that, okay, that is this reference here. It's in line with this reference because these people that have worked on this, that food additive increase body weight because the feed contain fat and carbohydrate. That only 1 rat in group E reveals slight reduction in body weight. Next line. From the result of histomorphology from plate A1, A2, A3, A4, and A5 showing section of liver, kidney, stomach, small intestine, and pancreas respectively, no pathology was observed using ×10 magnification. It's ×10. This is the control group, and from plate B1 the section is showing histology of the liver with mild necrosis of the hepatocyte as indicated with yellow arrows. This group was treated with the low concentration of the additive. Next line. Plate C1 is showing section of liver with severe necrosis of the hepatocyte, that is yellow, aggregation of the polymorphs, black arrow, and congestion of the central vein. This group was treated with 200 milligram per ml concentration of the additive. Next. Then D1 reveals section of liver with congestion of central vein, that is yellow star, and portal vein, black star, necrosis of the hepatocyte, yellow arrow. This group was treated with 400 milligram per ml concentration of the tetrazine. Next line. Then E1 is showing section of liver with necrosis of the hepatocyte and the central vein. This group was treated with the highest concentration of the additive, that is 600 milligram per mil. From this plate, B1, C1, D1, and E1 are revealing sections of liver with mild to severe necrosis of the hepatocyte, aggregation of polymorphs, and congestion of the central vein. This might have occurred as a result of the tetrazine effect on the liver. Himri et al. 2011. So all these statements, they are in agreement with Himri et al. 2011 and all these references. Let's move. Plate B2 is showing section of kidney with congestion of the renal vessel, and this group was treated with 100 milligram per mil. So concentration per mil, that's concentration of the additive. Plate C2 is revealing section of kidney with necrosis of the glomerulus black arrow and congestion of the renal vessel. Let's move. Then D2 showing section of kidney with congestion of the renal vessel. This group was administered 400 milligram per mil concentration of the additive. Let's move. E2 showing section of kidney with congestion of the renal blood vessel and necrosis around the renal vessel. This group was treated with 400 milligram per mil concentration of the additive. From plate B2, C2, D2, and E2 reveal the congestion of the renal vessel, severe necrosis of glomerulus. This effect is in line with that of Saxena and Shama. So I think they didn't arrange this work for me very well. Plate D4 is showing section of pancreas with congestion of black arrow. This group was treated with 400 milligram per mil concentration of the tetrazine, aggregation of the polymorph in plate C1, congestion of the renal vessel in plate B2, C2, and D3, and congestion of the central vein, portal vein, and pancreatic vessel in D1 and D4 respectively. So all may have occurred as a result of heart failure or other cardiac defect that leads in elevation of the central venous pressure and accumulation of platelets as a result of intoxication arising from the food additive that deposited in the liver and kidney. Next, summary, conclusion, recommendation, and contribution to knowledge. So here's my summary. Then conclusion. The activities of tetrazine food additive from this study have significant effect on the histopathy of the liver, kidney, and pancreas, thereby leading to cardiac defect. Next, recommendations. Further research should be done on the effect of tetrazine by extending the periods of administration. That's long-term therapeutic studies. Then further study should be done on other food additives. Then the food additive, either natural or synthetic, approved for human and animal consumption, is sure to adhere on the acceptable daily intake. That's ADI. Then human and animals should consume more of natural food additive than synthetic or artificial ones. The government of Nigeria, through National Agency for Food and Drugs Administration and Control, NAFDAC, that is the regulatory body, should intensify effort to monitor and reevaluate the use of food additive in the country. Then this contribution to knowledge. Next line. These are my references. Thank you very much.
Thank you, thank you, thank you. You can go back. You can go back. What a wonderful presentation. As he was presenting, I was looking at my HOD. The way he was following and shaking his head, I knew that they are in his domain. So he was at home. Thank you very much. Our HOD histopathology, cytopathology, Federal College of Veterinary and Medical Laboratory Technology, VOM, for that insights into that research. All right. So like I already told us, we'll still have another wonderful presentation. I suppose there are other abstract presenters, but I've not had any signal from any. So if they are not here, it means after this presentation, we might be closing the door for presentations. All right, so this afternoon, we have another special resource person here who is fully prepared to do justice to insights into film-based microbiology diagnosis with a special preference to malaria parasites. It used to give me trouble with some persons. In fact, where I worked, when I saw the records, I began querying the records in the laboratory about malaria parasite. And when I began generating my own records, there was problem. And they say, is this one different from the one that left? What was the problem? Everybody that came to the hospital, malaria parasite 1+. And so when I began giving a different result of sometimes not seeing 1, 2, as the case may be, it was a problem. And a senior colleague came, and then it now became an issue between me and him. I said, Oga, well, since you are now saying that practice in the private setting is different from practice in the government setting, meaning malaria parasite in the private setting is different from malaria parasite in government setting. Report the way you want to report. Let me report the way I want to report. At the end of the day, let the both of us breathe. All right. So today we'll be hearing from an expert whether malaria in private setting is different from malaria in government setting. I have here seated with us a well-read medical laboratory scientist. And if you want to permit me to go further, he has diversified into medicine. So he's not just a holder of a degree in medical laboratory science, he is also a medical doctor. All right, so he's a gentleman, like I did say. He had his MSc in 2008 at the then USC, now RSU. He has his BSc Health Science Education 2014, so you can see. At ESUT, is a certified assisted reproductive technologist in 2013 in India. And like I did told you, he had his bachelor degree in medicine in 2022, that's in Gambia, and is currently the Deputy Director, Medical Laboratory Service, as the HOD of Medical Pastology, FMC in Egua, and he is also pursuing his doctorate degree. Only God knows where this man wants to go. I have the privilege and honor, as small as I am, but with the permission of my chairman, to bring to this rostrum no other person than the double doctor I call him, Dr. Otuoke Bayelsa. Please, with a clapping ovation, let's make welcome another presenter, an expert in that matter. Thank you very much, Double Doc.
My people say big name kills the small dog. Okay, I beg you. Now only one I get. I never get the other one. Before they will change their mind. So, good afternoon. I don't know the order of protocol, I'm so sorry, but distinguished senior colleagues that are here, and every colleague that is here present, good afternoon. My name is Otuoke Bayelsa, and I've been asked to talk about insight into microscopy in microbiology. But just like he said, and with the consent of the dean of the faculty, he told me his area of preference where we should look at, and which is using microscopy to properly diagnose this parasite that has rattled most medical laboratory scientists in the country. Just like he said, because if you don't put 1+, the doctor will get angry with you. So in order to make the doctor very, very happy, so he can have what to treat, you just put 1+. But after today's discussion, I'm sure we'll have better insight into what the parasite is and be able to confidently report no malaria parasite seen when we are not seeing anything, and the skies will not fall down. So we'll get started. The parasite which causes malaria, okay, I'll take us through this, just a brief history of microscopy and how it is applied in our world today generally, and then we'll look at malaria just in brief, and then look at malaria microscopy, and then try to draw distinctions between the various species of the parasite. I'd like to inform us that we have the 3 species in this country, but most times we report only one, and that's the one we are familiar with, we tend to be familiar with. We are not expected to find Plasmodium vivax in our setting, but then if you have people coming over from regions where you have this parasite, then it's incumbent on all of us to know what the parasite looks like and be able to identify it in the blood smears of those persons. Of course, if these days of interracial marriages, if somebody is married to a spouse that is from locations where they have receptors for the merozoites for this parasite, then their offspring who are Nigerians most likely may have these receptors to be able to take this parasite, and then if they travel perhaps to visit their grandmother or grandfather and come back with the parasite, it's incumbent on all of us to be able to identify. So it's important also to know what Plasmodium vivax looks like. So let's have an overview of, so basically microscopy is the technical field of using microscopes to view objects or part of objects, that the naked eyes cannot appreciate. So microscopy actually started very small. People who repair eyeglasses, are the pioneers. But eventually it grew, and today we have optical microscopy, electronic microscopy, and scanning probe microscopy, which is applied even today to read X-ray films. So let's see the next slide. So this is basically the Dutch gentleman who started microscopy, and then Antonio van Leeuwenhoek took it further, and today we regard him as the father of microbiology, even though some persons think Robert Koch should earn the credit, or Louis Pasteur, whichever one, whoever you want to attribute that thing to, then you can. So microscopy-based microbiology has helped to revolutionize the field of microbiology by enabling scientists to have better understanding of the natural milieu, natural environment, of microbes, and thus paving the way for advancement in various scientific disciplines. Just in the world of Anthony van Leeuwenhoek and Janssen Zachariah, when microscopy started, it was like what happened to the world when Kelly Willis in the USA developed the procedure for amplifying DNA particles, so you can have a large number of them for proper study, which we now use in doing PCR and things like that. So that's the kind of thing that happened, or the joy that greeted the entire world when this gentleman came up with the idea of seeing things the natural eyes cannot see using microscopy. So let's see the next slide. So malaria actually is a life-threatening parasitic disease caused by Plasmodium parasites transmitted through the bite of an infected female Anopheles mosquito. We have Plasmodium falciparum, which is the one most common in our setting. We also have other species, Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, and Knowlesi, which originally has been animal parasite. It is important to make us understand that there are other species of Plasmodium, species in the Plasmodium genus, in the genus Plasmodium, which do not affect man. Birds, reptiles are affected by by this parasite. But those ones do not affect us. So only recently, Nolese, which used to be for animals, now evolved into being able to affect human beings. So next slide, please. So it is important to differentiate between clinical malaria from plasmodium infection. You have the infection when an infected female Anopheles mosquito takes a blood meal and then introduces the sporozoites into your bloodstream. During the window period, you don't show symptoms, there are no signs, but you're already infected. And then when you begin to manifest signs, we can either say you have uncomplicated or complicated malaria. So if you are infected and over time you develop uncomplicated malaria usually does not come with organ and systemic dysfunction. You show symptoms like myalgia, that's muscle ache, you can also vomit, have disturbances with your abdomen, and malaise generally. If you feel very uncomfortable, you can also run temperature, but then there is no organ dysfunction. So, but when there is organ dysfunction, we will not say you have complicated malaria or severe malaria. And I like to say that according to WHO, no medical doctor is allowed to say a patient has severe malaria until there is evidence of sexual stages of the parasite in the individual's blood. Meaning that the job or the responsibility of helping to diagnose a patient that comes to the hospital as having complicated malaria rests squarely on the malaria microscopist. Which means, if you say you didn't see any parasite, it then means the doctor cannot, because WHO has said, if there is no evidence of sexual stages of the parasite in the bloodstream, you shouldn't call it complicated malaria or severe malaria. It could be some other things, actually. So look in other direction. So our result will help the doctor to look in the direction of complicated malaria, because it's actually a life-threatening emergency. So that is why this workshop or this training is very important. So if we can take one thing today from this, from our coming, a better understanding of what the parasite is, then we'll be helping to save many lives in our society. So malaria infection malaria infection is the very presence of parasite in bloodstream. Okay, next slide. So these are values data we are very familiar with. How many cases worldwide, and then how many of them dying as a result of malaria, and how that it affects the pregnant woman and the child under 5. In Ghana, they've commenced the use of malaria vaccine. Nigeria is going to start. It's already here in our country, but we have not rolled it out as one of the policy measures for treating malaria. So let's go. Or preventing malaria from advancing, So this is the burden of malaria. Next slide. Next slide. So these are the etiology agent of the parasite, the 5 of them, and the percentage we have them, or the percentage with which they cause the disease. Next slide, please. So this thing used to rattle us when we were in school. Having read medicine as a medical laboratory scientist, I want to let you understand, or let us understand, that med lab is the most difficult aspect of medicine. I used to hear it before I went to medical school, but when I went to medical school, I saw how medical students struggle with laboratory medicine or medical laboratory science. But luckily I was cruising. I was on holidays during that period, because before they said it, I already know what they are trying to say. So this thing, no medical student wants to see it, because the next tomorrow it still confuses all of them, including practicing medical doctors. So normally the story has it that an uninfected female Anopheles mosquito takes a blood meal from an infected individual, which means it is the human being that infects the mosquito in the first place. Because the mosquito only needs the blood meal to be able to mature its egg. Most vampires like to take a blood meal for such purposes. Most hematophagous insects take blood meal for such purposes, for the purpose of maturation of their egg. And so the man gives the parasites to mosquito, then the female Anopheles mosquito, and then hopefully it's expected that the mosquito would have picked male and female gametocytes or male and female microgametes of the parasites, and then in the mouth part, in the gut of the mosquito, as they are developing, the microgamete, which is the male gametocyte, will begin to exflagellate, and then genetic particles of the male gametocytes would fuse with the female gametocyte and form an eukinete. So this eukinete, has the ability to move. The word eukinete means it can wriggle, it can move, and then get further into the thoracic muscle of the mosquito and develops into an oocyst. Then within the oocyst, a lot of things are happening until sporozoites are produced. These sporozoites then swims back to the mouth part of the mosquito, and then at this point the mosquito is ready to infect a human being. Initially the mosquito was infected. Now the mosquito is ready to infect an unsuspecting human being. So which means the mosquito was just a medium through which the sexual stage of the parasite was cultivated or developed. So upon taking another blood meal, the sporozoites are injected into the unsuspecting individual, and depending on the species, it will take some 8, 9, 10, even 16 days for the parasite to develop within the human system into sexual forms that will begin to cause disruption to the system that will lead to the signs and symptoms that makes the patient come to see the medical doctor, and for which the medical doctor sends the patient to the lab to check if there are parasites in the blood of the patient. So normally, the mosquito would sometimes bite you in your leg or your shoulder or anywhere, especially the exposed part. And then through hematogenous spread, these parasites or sporozoites are carried to the liver. And then the liver, they enter the hepatocytes and develop into schizon. As they develop, they get to a point where these hepatocytes are not able to contain the schizon. And while that is happening also, the chromatin or the nuclear material of the parasites and the cytoplasm are dividing. And a little part of the chromatin and a little part of the cytoplasm comes together and they form merozoites. So different species will have different number of merozoites within the hepatocytes or within the schizon, the unfolding schizon. And then when the hepatocyte can no longer take the schizon, we call it schizon those days, but later I found out that the right pronunciation is schizon because it's a German word. So then the hepatocyte is burst open and merozoites are released. Now, development of the parasite within the liver cells is called the exoerythrocytic cycle of the asexual reproductive stage of the parasite. So when the merozoites, schizon, burst open the hepatocytes and release the merozoites find themselves back to the peripheral circulation and now begin to infect red cells. So different amounts. I'm saying this so that we'll not have to go through many slides that we'll find there. So it's a story I'm telling you. So just enjoy the story. So different species of the parasite will behave differently when they get to the red cells. You know, and that this defines the veracity of the species. You know, so while the merozoites are migrating from the liver compartment to the peripheral circulation, some species would choose to stay back. The Plasmodium ovale and Plasmodium vivax have the tendency, some of them sometimes have the tendency to stay back into the liver. In fact, some school of thought believe that it was the sporozoid that entered that refused to develop and just stays there dormant. While some school of thought believe that it is at the Schizon stage that quiescent, that resting stage is achieved. So, but then, so long as the parasite is contained within the liver and resting there, could be for weeks, for months, for years, we refer to them as hypnozoites. So that's how the concept of hypnozoites came about. So until when they choose to reactivate, just like tuberculosis sometimes get there, and then after a while to reactivate and then give you even herpes also virus does a similar thing, and then gives you zoster afterwards. So for those parasites that all of them do not empty, all the merozoites do not empty back into the circulation, it then means that you would have to do extra to be able to clear those hypnozoites, which means what species you tell the medical doctor that you're seeing will also determine what drug he's going to give to the patient. So I'm saying this so to underscore how important it is for us to do our jobs and do it very well when it comes to malaria disease, and how the doctor functions or what the doctor does to the patient. So it's a contributory role, and we must not absorb ourselves of anything that happens to the patient if it is due to our misdiagnosis in the laboratory. Because sometimes we blame the doctor only for killing the patient. I used to blame the doctor also for killing the patient. But now I know that doctors, in fact, maybe it will be a story for another day. When you are inside the thing, that you know how it feels and what actually obtains within it. Ordinary potassium can keep a patient result that they want to see, can keep a patient further in the hospital. And every patient who comes to the hospital is supposed to do urea electrolyte creatinine, especially if there are systemic manifestations of disease that have affected the systems. So, and these are things, results that are supposed to be seen on time, on real time. But if the result is not there, the doctor has to do something. The doctor will not just watch the patient and the patient go into or die or something. So the doctor will keep doing what he thinks he can do. So if we don't get our results on time, including the malaria result and every other result we are supposed to generate and give to medical doctor, we will share the blame when the patient dies. That's the point I'm trying to make. Because I've seen in real time where they are searching everywhere to see even PCV result. Patients have been laid on a theater bed, and suddenly say, what is even the PCV, the last PCV of this patient? Can we see the result? They are searching everywhere. Eventually they found it. One was done on Friday. I think they had 36%. And that one was done on Monday. Theater was on Tuesday, and they had 46%. And they brought the two results. And they say, Faith, see your result. Because they believe I'm the main lab scientist in their midst. They still see me as main lab scientist. But my friends who are main lab scientists, they are not seeing me as doctor. So I don't know where I even stand right now. God will have mercy on me in Jesus' name. So that is just on a lighter note. So that's how important our result is. So I always tell them, don't worry, I'll go find out what transpired. So, and they're actually happy to have me in their midst because they think I will solve a lot of their problems. Yes, that's, so they're happy. But I don't know if my friends, my support base, my primary base, if they are still liking me. I don't know. I don't know. With time, we'll know whether they are still liking me. But I beg you, please, still like me. I'm a male lab scientist. There was no way I could have become a medical doctor at the age I went to read medicine, if I didn't have medical laboratory science background, it was not possible. Where would I have started from? So it is medical laboratory science that made me a medical doctor. So why would you not reject your own? I mean, don't do that. Don't do that. One consultant told me, you are now our spy, not their spy. Big consultant in the hospital. And they were asking me, are you now Jehosi or enemy? Which one are you? I said, I come in peace. I come in peace. Okay, who should head hospital? Is it doctor or Jesu? These are kind of questions I get in their midst. So there's war, there's fight. So if you think that the war is ended, is a lie. The only thing that can make you stand out is if you know this thing we're talking about today. You give a result, and when they come back, they go to anywhere, it is that same result. That is when they know that actually, we know that we're actually winning that fight in the way we're supposed to win it. Because now see finish fight. The fight is nothing but see finish fight. But they think you don't know enough, or we don't know enough to have the privileges that we have in the hospital setting. That is just what the fight is all about. So any day we sit up as professionals and do what we're supposed to do, generate result in real times, say there is no MP when there is no matter how they try to stretch you, and they take the sample elsewhere and they generate the same result, of course, the fight will start dying small. So that is just that. So back to our malaria parasite. So eventually now we have the merozoites in the red blood cells, and then depending on the species, you can have multiple infections with red cells, depending on the species. Most species will not, when one merozoite has entered, others might not be interested in infecting that red cell, but Plasmodium falciparum does not actually care. You can have 5 merozoites within entering one RBC, and of course each merozoite will develop into trophozoite, early, half intermediate, and then mature trophozoite, and then form schizon. Each of them, imagine each trophozoite, 5 of them formed within a cell, developing also to form a schizon or schizon. That means that red cell would break down faster than if one had entered there. So that's why it's more deadly. Okay, so let's go. So then they will develop into schizon and then produce merozoites, burst open the red cells, attack more red cells, and the vicious cycle continues. Let's go. So yes, normally in the hospital, the doctor will see the patient, take history, which will include fever. Depending on the state or the class of the malaria, if it is severe malaria, there are more symptoms and more signs. So now we're getting into the business proper. So then, and then take some vital signs and all that. So this slide is one of the most important in our discussion today. So we need to know what we are looking for when we are under the microscope to see viewing the malaria parasite. Now you are looking at 2 things. You are looking at the red cells. For you to make proper diagnosis, you are looking at the red cells, and you're also looking at the parasite. How has the parasite evolved after entering the red cell? And also, how has the red cell morphology evolved as the parasite is developing within the red cell? This information, if you have at your fingertip, it summarizes every story we are going to tell here today. So now, the parasite you are looking at, what are you looking at when you are looking at the parasite? You want to see that you are seeing a cytoplasm. You want to also see that this cytoplasm has chromatin, which is nuclear material. So these 2 things, very important. Then you want to look into the cytoplasm. Are you seeing pigments? What kind of pigment are you seeing? Because it also helps you to define the species of the parasite. Then the vacuole we are seeing, has it become smaller, or is it well expressed? Some species do not have big vacuole like that, while some in their early stage, their vacuole is well expressed. especially in the trophozoite, we're looking at, because this is a trophozoite actually, trophozoite stage. So I've talked about the chromatin, I've talked about the cytoplasm, I've talked about, within cytoplasm we should see the pigment. So now on the red cell itself, the red cell, did it become enlarged after it became infected by the parasite? Or is it still maintaining its normal size? Did the shape of the red cell change because there's a parasite inside of it, because it is infected, an infected red cell? Or has it remained the same? This is very important. Now, has the red cell formed to produce stipplings, which also stain in different characteristics manner and also have different morphology and present in different quantity? All this will help you to say whether you're looking at a Plasmodium falciparum, Plasmodium malariae, Plasmodium vivax, Plasmodium ovale. I don't know what molese look like, so don't ask me at the end of the day, because I don't still know it very well. Did we get that clearly? Yes. And it shouldn't also be a source of concern, because we don't have much of it in our environment. So the ones that we have, let's be able to identify them properly. So I've talked about this, the cell, the host cell, and then the parasites. Okay, let's go. So this is, now, from what I've said, because the way I'm talking about is, tomorrow you have hands-on, I believe. Good. So when you go for your hands-on tomorrow, what I'm saying, you'll be looking for it. If you are here and you're a medical laboratory scientist and you are a senior scientist, or you are just beginning your career, and you are trying to diagnose, do microscopy, blood smear to be able to say whether the patient has malaria or not, and you're making only tick film, you are a quack. Even if you have worked for 30 years, you don't know what you're doing. I'm sorry, I'm very sorry. I can be very blunt. My boss, Mr. Solomon, taught me bluntness. That's one of the things he taught me. I'm very, very sorry. And this is the way he will talk. He will say you're a quack. Because of course, if you're not a quack, if you're a professional, you will know that there is no how you'll be able to do proper species identification if you are not seeing the parasite inside the red cell. That's why I've taken time to explain what will happen to the red cell when it's infected by a parasite, so that you know how important that thin film is. Some people just does one shaka thing and then they stain it anyhow and then bring it, pass it to you, and you are reading it. You will not do a good job. So proper malaria microscopy starts with proper film making and then proper staining of that film, proper preparation of your stain, proper preservation of your stain, and everything, proper preparation of your work solution, because every day you're going to prepare what you're going to use to stain for a period not more than 6 hours and all that. You throw it away, so you must know what quantity you are going to prepare so you don't waste reagent. All that I'm sure will be taught you tomorrow in your hands-on. So first, your smear must be properly made and then properly stained and then brought before you, so you can see the parasite outside the red cell and inside the red cell. And most importantly, the two films, thick and thin film, must be made on the same slide, not separate slides, because we will use, they will teach you tomorrow that you use the thick film for parasite detection, and then you will now use your thin film for species identification. I think that's the thing we know very well. So if you do not have both on the same slide, how would you be able to, if you're seeing something that looks like a parasite on your thick film, which is the one you normally view first, the next thing, professional thing to do, because sometimes these parasites are very confusing, to be very frank with you, irrespective of the number of years you've seen it, unless you are doing malaria microscopy routinely and daily, you still have some challenges. So whatever you see looking like parasite, plenty of them, if you look at the thin film, and you're not seeing parasites in the red cells, it then means that whatever you're seeing there are basically artifacts. Because if the parasite, because it was from the red cell that was lysed, in the preparation of staining, that release those parasites, if they are parasites. So you cannot now check your thin film, and they are not seeing parasites. It doesn't make sense. It doesn't add up. So if you work that way, it will help you not to be able to say you are not seeing parasites when actually you are not seeing parasites. Because you have helped not to box yourself into a corner. You have like something controlling what you do or what you say. So when you make only thick film because you want to save reagent and you think, you only generate bad results. There's no doubt about that. So but you both are on the same, so you just move and then you check and then you scan through very well. Usually the samples with low parasitemia is the one that you spend more time on looking for the parasite. So if it is low parasitemia, maybe you saw in the thick film maybe like 5 things that look like parasites, and then you scan through maybe like 100 fields, you cannot find anything. Most likely what you saw could not be parasite, and then you can beat your chest and say no MPC. Why somebody is busy writing MP for every disease, writing MPC? That is the magic. That's how to do it. So you must go the extra mile. So for the Plasmodium falciparum, I've already told us what you are looking for. So now we are seeing the films. So you see normally, let me just tell us, the chromatin for Plasmodium falciparum usually compact and dark brown, dark to dark brown. So Plasmodium falciparum and Plasmodium ovale, both of them have dark brown chromatin, but that of Plasmodium falciparum can go from dark brown to dark permanently. So you have these two at the back of your mind. So for their chromatin, the staining reaction you will get will be that dark brown for ovale, dark brown to dark for Plasmodium falciparum. Then Plasmodium vivax, the chromatin is golden brown. Golden brown. Then the other one that is left, which is Plasmodium malariae, is yellowish brown. You get it? Golden brown. Gold and yellow look alike, right? Yeah, so golden brown, yellowish brown, dark brown, dark brown. I think that settles it for what the color of the chromatin should look like. I need to get some fillers, so I know that I'm not talking to myself. Because I'm talking to us as colleagues, I'm talking practically what you expect when you sit there, and that what will help you understand that what you're seeing is parasite. Are you coming to tell me that my time is up? Okay. Because I'm enjoying myself actually. So then, that is that about the chromatin. For these 3, for these 4. I'm doing it because we might not have all the time to go through all the slides. So when I'm done, we can just be looking at the slides and just in less than no time we'll finish them. So I've done for the chromatin, no, not chromatin, sorry, the pigment. The pigment, not chromatin. The pigment, the other chromatin will always stain pinkish actually. Chromatin will always stain pinkish. I'm talking about the pigment. Because I told you that they have pigment, they have chromatin, they have cytoplasm, and they have, in the rest side, they have basophilic stipplings. But this pigment we're talking about is pigment on the cytoplasm of the various species. Do we get it? So that's that. So then, for the basophilic stipplings, for Plasmodium falciparum, you have Morar's dot. You can call it Morar's dot, Morar's spot, or Morar's cleft, as the case may be. So, and this will locate it on the cytoplasm of Plasmodium falciparum. Now, because the rest cell that is infected by Plasmodium falciparum can become serrated, like that one there is looking serrated, the serrated edge, the edge looking serrated. Sometimes the serration, it becomes very deep, that begins to look like tongue of flame, and then we refer to it as flame form, the flame form. Normally, when a red cell is infected by Plasmodium falciparum, it does not cause the red cell to enlarge or to be enlarged or to assume some amoeboid shape. No. So now, if you want to be sure that the parasite you're looking at inside that red cell, not the one in the thick film. Thick film just told you it seems there are parasites here. Now you have gone to your thin film, and then luckily you've seen parasite. Now you want to tell us what kind of parasite am I looking at? So you look at the parasite itself. Look at the parasite itself. And then after that, you look at the red cell itself, what has happened to it. So if it is Plasmodium falciparum, hopefully, most times what we see is the trophozoite stage that we see. So I'll talk more about the trophozoite stage, because the Schizon stage, even late trophozoite, you don't normally see it on except maybe the malaria becomes so severe and all that, and then good. So now, the red cell containing Plasmodium falciparum, on the body of the red cell, you have Mora's dot. You can call it Mora's dot, Mora's spot, or Mora's cleft. This membrane of the red cell can become serrated. When serration is deep, it looks like tongue of fire, and we say the flame form. The red cell also is not enlarged. It maintains its normal size. How do we know that the red cell is not enlarged? You compare the size of the red cell with the size of an uninfected red cell adjacent to it. So you look at both, which means if the one that is infected is enlarged, it will not be the same size with the one adjacent to it that is not enlarged. Am I communicating? So that's how you establish whether it's enlarged or not. So Plasmodium falciparum would not enlarge the red cell. Good. So now you look at, you've seen, maybe I've seen some red cells, infected red cells, they have serrated edge. Now you look at how many parasites are within this red cell. Most times, the ones you find behaving that way, having 2, 3, 4, sometimes even 5 parasites in one red cell is Plasmodium falciparum, because it's in a hurry to destroy the red cell and keep, like that. It doesn't care, That's why it's more virulent. So, if you see like that, now let me tell you something. In my medical school, they brought this thing. In my MP exam, second MP, that's what they brought for parasitology. So I finished work. I was the only one that identified it as malaria parasite to start with. And secondly, I told them the species. The next day during Viva, the consultant who came from England for the exam said, yesterday you made a diagnosis at station number something. Tell us how you arrived at the species of the parasite. You said, and everybody was ready to listen. So I took them to the cleaners. At the end of the day, that was where the Viva ended. Everything about microbiology ended there. They said I should go. So when I say it is lab science that made me a doctor, I know what I'm talking about. So why I'm saying this, so that when people say you don't know much, is a lie. It's not true. The medical lab scientist is very, very loaded in his area of calling. And all we need to do is to deepen this knowledge, have it at our fingertip, and not disappoint at any point in time. And I'm telling you, this fight will start ending gradually. And many doctors will stop specializing in the medical lab area. Perhaps, if they want to have a consultant pathology, it will be medical laboratory scientists who decided, maybe in fact, I'm hearing that they want to do something. A consultant was telling me one of the ways to end this fight is to create a way through which anywhere you want to go, you can go. If you are here, suddenly you feel like you want to cross over. They give you some years, you do it, and then you are there. That's what they are thinking at the level, because they are tired of the fight too. So that is just a propos that I gave to you. Don't quote me, don't say I said. But the fight actually is not helping anybody and also not helping our patients. So that was, I made the diagnosis to special level and I just finished work. Because they also brought the ones that you have more than a multiple infection of the red cell. So I saw a coliform, I saw serrated. So all the features of Plasmodium falciparum I saw. I just gave it to them and they were shocked. So because they don't know my background actually. So if you're a male lab scientist, be a very good one. Don't be a nyama male lab scientist. Don't be a nyama male lab scientist. If I was a nyama male lab scientist, I would not have MBCHB today. So let's clap for medical lab science profession, please. So good. So having said that, we're describing the Plasmodium falciparum. Yes. So now, multiple infection of the red cell is there. Serration of the red cell margin and basophilic stiplings, which are Mora's dot or Mora's cleft or Mora's spot you can find. And then normally the size of the parasite in the red cell is usually 1/5. If you have only one, especially when it's just entered that early stage, usually 1/5 of the size of the red cell itself. But if it's other species, it could be 2/5 because they are big, usually bigger at their early stages than Plasmodium. Then you can also see the acoliform or the marginal form, where the parasite lines itself to the margin of the red cell. So that you always see most of the times. You can see double chromatin dot for the parasite. So you see, and usually these ones you normally see it on your thick film. You also see on your thin film too. But in the thick film, and it will not look like the usual parasite, because you have broken the cytoplasm and stretched the parasite when you are making the film. So you now see two chromatin dots, adjacent each other, and then the cytoplasm that you have already broken when you're making your film, stretching out. That's a parasite. But you need to also find similar parasites within the thin film to be sure of what you are going to report. And honestly, there's nothing as seeing something so sure that that's what you're seeing and then you're reporting it. You will approach anybody with a lot of confidence, and at the end of the day, the person will be very convinced that you actually saw what you saw. So that you find in Plasmodium falciparum, double chromatin, appearance, a coliform, that's the marginal form. You also find it, and other things I have mentioned. Then this is the differential diagnosis I'm already doing. The other ones we are just going to watch picture. By the time I finish this slide now, we're almost done. We're done. And I can be sure that with this, we cannot do this within the time available to us, but whatever we can get today, let it be a plus. Let it be a value for the time we spent in this place. So for Plasmodium malariae, let me take Plasmodium malariae. It does not also enlarge the red cell. So Plasmodium falciparum and Plasmodium malariae, the red cell will not be enlarged. Now, now the basophilic stippling for Plasmodium malariae is called Zeeman's dots. There are usually plenty of them. Zeeman's dot, plenty of them, very plenty of them. Initially, I already told you the pigment that you're going to find on the cytoplasm of the parasite from Plasmodium malariae. What did I say it is? What did I say it is? No, Zeeman's dot is stippling you find on the red cell. Now, on the parasite, you find pigment. What is the name of the pigment you find for Plasmodium malariae? I gave you a tip how to remember it. Plasmodium falciparum, the pigment that you find on the cytoplasm, will be dark brown to dark for ovale, Plasmodium ovale, you will find dark brown. For Plasmodium vivax, you will find golden brown. Then I'm asking you now, for Plasmodium malariae, what will you find? Yellowish brown. Exactly. Clap for yourself, you are listening. So and this is how you actually find it. If you prepared your stains properly and you prepared your film properly, you will see these colors actually. You prepared your stain very well, the pH, you've already determined it, and all that. You will see exactly what we're describing. You will see even the stipplings. You will find the stipplings. You see them there. But if the pH of your stain is not good enough, you cannot see the stipplings. They will not appear because they react to the pH of your stain. So that's why in most of the labs you don't see the stipplings when you do your MP. That's why you don't see. But if you properly quality control your reagent, you will see these things. Okay, good. So now we're looking at Plasmodium malariae. So we talked about the stipplings, which we say is yellowish brown, right? Then the next thing to talk about is the morphology of what the parasite look like inside the red cell. Now, inside the red cell, there is something we call band form. Band form. I'll show us band form when we get to that slide. The band form. Now, inside the red cell, it will line itself transversely, like crossing itself edge to edge. And some of them will even begin to look like an opener. The opener is used in opening Fanta and Coke. The normal opener, not this other one that the normal opener we used to know. That's how you find it. We will see it when we get there. You will see it like that. So it looks that way. Note, go back. It does not. No. You are not. No, that's not where you should be. Go back. I will not talk about these things because the gametocyte stage is not diagnostic. You only say that you saw that, but doctor will not start treating a patient because he saw only asexual stages that will make a doctor treat a patient. That's why I'm interested in the asexual stage. We'll just keep those slides. So that is Plasmodium falciparum there. Then that's Plasmodium malariae there. Then the one with James's dot is Plasmodium ovale. And then the other one is Plasmodium vivax, the one with Schuffner's dot. Schuffner's dot is the basophilic stipplings for Plasmodium vivax. The parasite itself, the cytoplasm becomes amoeboid as it is growing. Normally, at their very early stage, they all almost look alike. But as they are growing, they begin to change, the shape begin to change. Both the shape of the parasite and shape of the red cell begin to change. So look at it looking amoeboid, Plasmodium vivax, And then the red cell also look amoeboid too. It's enlarged and it looks amoeboid. The parasite looks amoeboid. Then the ovale will turn the red cell into an ovalocyte. That's perhaps where the name comes from, Plasmodium ovale. Look at the red cell there. And then looking bizarre with some fimbriae kind of, some of them. And the stipplings you find on the red cell is the James's dot. Now, if you look at the parasite inside the red cell for Plasmodium ovale, just look at the one that is very round, and then look at the parasite. Look at the parasite, visualize the parasite and the red cell together. It looks like an eye, also somebody's eye. So we'll call it O's eye. The eye of an O looks like the eye of an O. So that's why. So under the microscope, when you are seeing it, it will be looking like you. You'll be looking at the parasite, and the inside the cell will be looking at you. So both of you looking at yourselves. So you know you are dealing with Plasmodium ovale. Okay, let's go. And the James's dot is usually more granular and bulky. So roll out the slides. Next slide. Next slide. So Plasmodium falciparum. Look at what I was saying. Double chromatin appearance. Just watch. You now watch to see those things I've been saying since. That's my own strategy. So you know whether you are learning something. Good. So that's why I didn't show you the slides until I've done the explanation. So you too will be appreciating what I've taught you as we are watching the slide. No, go back. Good. So now plasmodium falciparum trophosite stage. This is thin film. This is thick film. This is how it must be in one slide. If you're a good lab scientist. So that is the way it develops, from that up and then down. Now look at the red cell. The red cell that is not infected. Look at the one that is infected. They are the same size. There is no differential in size. Now look at the marginal form I talked about. Look at it lining itself at the margin of the red cell. So if you are seeing that one, you know you are seeing plasmodium falciparum. Now look at the double chromatin I mentioned. I talked about it, right? Now you are seeing it. So that's typical of plasmodium falciparum. Now look at that cell. How many are you seeing inside? So that red cell, a red cell is supposed to stay how many days? But that red cell would finish in less than no time. That's why this parasite is very, very dangerous. So 5, just 5. And each of those 5 is expected to develop and grow into schizon. So, of course, that red cell will finish in less than no time. Now, I talked about the flame form, right? Are you seeing a parasite with invaginated edges? It could also affect the red cell. Now look at the cell now. It's crenated, right? Now the Morus dots, how you know it's a Morus dot? You can count the Morus dot. I've counted Morus dot in my lab in FMC in Agua. And yours sincerely found out that what the book says is true. Of course, this has, after my training in malaria microscopy, I wanted to make sure that everything I learned is implemented in FMC Negua. So MP for every intern coming to my lab is by force. You must know it. If you don't know it, you can be there till any day you decide to know it. There is nothing let my people go. Maybe that's why I'm the wicked scientist in FMC Negua, in quote. Because my own way of teaching is that you must know. It's not optional. You must know it. Because I did my day, you came, you say you want to do internship. And I'm here, I'm ready to teach you. Because that's why I'm earning salary for. You like, say anything, you must know it. Some interns have run away from my lab before. They ran away. Yes, sir. Because let my book go to where now? Where are they going to? To go and be killing people and bringing shame to the profession. I was trained in a hard way. I'm very proud to say that I'm a graduate of Federal School of Medical and Sciences, JOS. I did AIMLT. For some people who think that AIMLT is substandard. It was AIMLT I used to get that entry in University of the Gambia. Not even my MSc. When they hear me, so if you think it's AIMLT that made me scientist, that made me a doctor, like I tell you now. It's not the MSc I did in USTO. That's where I got the foundation. So if we have decided to go the route we have gone, it is incumbent on all of us to make sure that we don't water down the profession. And if you're here and you are part of those watering the profession, shame on you. Yes, sir. I know I'm talking to all of everybody here is male lab scientists. I have become a medical doctor, but I'm still very passionate about medical lab science. More than even some so-called fathers of med lab science. Some med lab scientists still believe that AIMLT degree or qualification is substandard. I don't know how. And part of the reason I went to read medicine to prove that point that it's not true. That a med lab scientist can become a doctor if he wants to. Are you getting me? Yes. So, I gave you some things about myself that you didn't read. After my training, I came to FMC. It was special hospital in Agua. As a copper, I started the microbiology department. As a copper, unaided, unassisted. That's the quality of training we got during our time. So what is happening now? So I have not become a medical doctor and then it's hooray. No. Because while there, they still see me as scientist. And it is the lab science that I have is what I used to pass them. I have two, they have only one. So why should I now go and be, talking down on my lab science profession? But then our people talk down on our profession. Even after retirement, they are still saying that that AMT is HND. Even after the Federal Minister of Education has written a document to say AMLT is equivalent to BSc, they still in their small head think that AMLT is not a degree. But it is AMLT that has made me stand here today. Or stood here. Sorry, permit my English. I don't know which one is correct now. So please, what I'm trying to say is we must not water down the profession. And I think that's the essence of this conference. Because film reading is the core calling of a medical laboratory scientist. That's why in the logo of our council, you see a microscope there. Is that correct? Even a logo of our professional this thing. You see, say give blood, save a life. You see microscope there. So microscopy is very key, and we should not joke with it. It's not mumbo jumbo. So we should know this parasite inside out. So now, as I said, that's how they are appearing here. So let's go. This plasmodium falciparum. So if you count the Morris dot, you will not find more than 20. But you can't see it in your Nyamanyama slide. Your slide has to be properly prepared. Let's go. So this is how you see it in a thick film. So sometimes you are confused. Don't know whether you are seeing parasite or you are seeing platelets, degenerated platelets or something. It's your thin film that will guide you. Okay, let's go. So just keep cruising. And so just appreciate what you are seeing. Parasite inside the rest. My friend, I'm one in charge. Who is controlling that thing? Where are you? You want to go? So you are seeing parasites, you are seeing the same thing, marginal form, double chromatin, the red cells are not enlarged and all that. Okay, next one. Okay, just to compare that the red cells are not enlarged. Continue. Continue, please. Keep going. I made this thing very elaborate so it can be a source material for you. In your quietness of your home, you can pick it up, look at it, and then get it better. So these are Shizon stages, which you hardly see, but if you are able to see it, it's good. So let's go. Let's go. Let's go. Keep going. Okay, okay, yes, okay, show next slide now. Yeah, so this is the gametocide stage. You can also but it doesn't necessarily mean whether, you can just say you saw gametocide, but if you're able to tell them it's female or male, it's just academic reasons. The male one is only in malaria parasite where the male organism is bigger than the female. Normally the female is really bigger than the male in most organisms. So but in the malaria parasite you have the male bigger than the male, less crescent than the female. The female is more crescent like moon, half moon, than the male. And then there's this dissemination of the genetic material of the chromatin, is disseminated in the male than in the female, where it's more clustered centrally. Men, I would like to work now. That's how to know it. So when you see the one that doesn't, the materials have disseminated, you know that, and less bigger, less crescent, is a male. The one that is, women are more conservative. Women, they close their leg there, you know. But men who like to waka waka. So that's how it is in the MP. Okay, let's go. So let's go. So that's the gametocide stage. Normally, if you report it to medical doctor, he will think that the patient has had treatment for malaria. Maybe he will watch the patient and then probably reschedule another visit for the patient, or maybe treat some viral causes of fever. But most times it's fever that takes patient to the hospital, and there are many things that can cause fever. You know, pneumonia can cause fever. Viral, respiratory diseases can cause fever, and all that. So, so he would wait a little bit and see, and just give some things, So that's that. Okay, so let's see. Next one. Keep going, keep going. So this is just, okay. This is talking about the host cell, all that I've explained about the host cell, the various components. Next slide, please. Next slide. I talked about this already. Keep going, please. Next slide. So this is Vivax. Now, we're looking at Vivax now. You see the cell there, the first cell up, first row. The one that is infected, is it the same size with the one that is not infected? Is it differential in size? Yeah, differential, right? There are stipplings in the red cell that is not infected, but there are stipplings in the infected red cell, right? Good. Now, the stipplings there, what should be the name of the stippling? Schiffner's dot, because this is Vivax. Schiffner's dot. Okay, and there are usually plenty of them. Now, as the parasite is developing, it's becoming amoeboid, right? And the breast cell too, also wobbling as the parasite is developing. So this is what you see. In fact, you see snake, parasite like snake. It will have the features of parasite too. That chromatin dot over there, you will see, and then it will look very wobbly. Don't discard it as nothing. It is parasite you are seeing. And if you know that it's Vivax that you are seeing, write it there. And nothing will happen. Somebody was treating malaria severally in Port Harcourt. Anywhere lab they go, they give them MP. Any lab they go, they give them MP. So contacted one of our consultants. We worked together during the Sentinel's DTET. I was the site scientist for Bayelsa State. He told them, come to FMC Negua. Let me take you to the lab. Any result he gives you, that's what it is. I was in my office, Dr. Finomo and Dr. that one now that become a community medicine consultant. They walked in. They said they brought a sample from Port Harcourt. Please, they were begging. I didn't stand up, of course, stand up for Una. Before I became a doctor, I was very stubborn. So I sat down. They came to my office now. So they were standing and begging, say, please, we brought this sample so you can help us confirm whether this patient really has parasite or not. They've gone to several labs in Port Harcourt and they are giving them the same result. I said, okay, consider it done. So they went and did the formalities, paid and everything. So I gave instructions, prepare the slides, I'll come view it. So when they were ready, they came and called me. I went and read it, and there's nothing there. There's no parasite there. And I gave them the result. And they thanked me very well. And I didn't receive any call any day to say that, Because the result of my performance in the training that we did, several trainings that we did, that got me, straight into WHO certification as a malaria microscopist. He got the result from Abuja. They wired it from Abuja to him. So since that, the man started respect me very well. Yes. So I earned my respect before I became a doctor. It's not doctor that made me get respect to. I earned my respect. I'm a lab scientist. And that's why I'm still very proud one. Very proud one for that matter. Warn my people, warn them. They are not liking me. Warn my people in FMC. All of you should warn them for me. Some of them are not liking me. They say now I'm a doctor. They say, now me, I'm a doctor. They are seeing me as enemy. Me, I'm not enemy. I'm still lab scientist. So a very proud one. That is on a lighter note. I did not say anything. Okay, good. So this is what you're going to see. Next slide, please. So take film, you see. Next slide, next slide, next slide. Let's go. So it's making comparison, enlargement of the red cell, change in red cell shape, and then the uninfected red cell, what they look like. Okay. Let's go. Let's go. Let's go. Let's go. Keep going. Keep going. Keep going. This is the Shizon stage. Keep going. Now, let me also tell us what mistake we used to make. As the parasite is growing inside the red cell, so long as you are watching the thin film, you are supposed to see the parasite inside the red cell. Whether it is the trophozoite stage, whether it is late trophozoite, Shizon stage, or gametocyte stage, you are supposed to see it inside the red cell, not outside the red cell. Not outside the red cell. Anything you are seeing outside the red cell in a thin film is not a parasite. But what happens is that as the parasite grow, they become so big, especially the Shizon stage, because that's what will make them burst the red cell. They grow, attain the size of the red cell, and keep growing until the red cell bursts open. So you will not appreciate the red cell margins very well during the gametocyte stage, especially for other species, Malaria, Vivax, and Ovale, because as they are growing, they are also growing, roundishly like the red cell until they attain the same size of the red cell. You will not be able to see the red cells properly. So let us bear that in mind. So when you are looking for the parasite, know where you're looking for it. Okay, let's go. Let's go. Keep going. Keep going. Continue. Continue. Now, wait. Typically, this is what I was talking about, what I just talked about. That's gametocyte stage inside the red cell, but you are no longer appreciating the red cell. Is that? Now you can think it is maybe just an artifact or something. But now you know it's a parasite, so you have to look at it very well. Okay. So let's go. Let's go. Continue. Continue. Good. Wait then. This is malaria. I talked about the band form, right? So that's the band form you're seeing there. Transversely, it's going across the red cell with all its features. If you look down, the very older ones, see them looking like opener, right? Are they looking like opener? Can you see the opener? You are seeing the opener? Yeah, good. So when you see it like this, when you see it like this, you are looking at Plasmodium malariae, and you write it boldly, and the skies will not fall down. Eh? Good. So let's go. Let's go. Showing you band forms. You see, it's going as a band form, and it has almost covered the entire cell. So you see that thing, wait. You see this two this way, these two this way. Something with the pigment, that's Plasmodium malariae, right? What did we say is the color of the pigment? Yellowish, correct. Now look at it, it's in the middle there. And then the Shizon is already dividing into merozoites, and the merozoites have clustered around the pigment, looking like a rosette, a flower. Are you getting it? It looks like a flower that somebody wants to give, a man wants to give his wife marriage anniversary or something. So you can see that. When you see that, know that you are seeing Plasmodium malariae. Let's go. Shizon form. Continue. 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 The same thing we talked about. Banned from. Okay. This is ovale. You can see, very bizarre. It has turned the red cell into an ovalocyte with some fimbriae. Now you're also seeing the eye of the bird, right? You are seeing it. Okay. So let's go. So the thin film, you see. Let's go. Let's go. So normally, as the parasite is young, the body it has well expressed vacuole, cytoplasm. But as it's growing older, the vacuole is getting diminished, and then the cytoplasm is becoming thick. That's how it happens. Okay, let's go. So look at this is schizon stage, early schizon stage. You can see it's in the schizon stage. You see the parasite trying to, when it is older, it's trying to divide into merozoite, because the schizons the parasite becomes a schizon and then schizon, and the schizon divides and then form merozoites, which are released. So that's what you're seeing there. But then, so long as it has infected the red cell, it must enlarge the red cell. That's what you're seeing there. Now it has turned into an ovalocyte. You can see the shape of the red cell is no longer like the normal red cells. Let's go. Let's go. Let's go. Continue. 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 Everything that is here, I've already said it. Everything that is here, I've already said it. Keep going. Just watch the pictures and try to do the diagnosis by yourself. So please, when you go home, based on what you've learned or what the parasite should look like, go through the slides and try to have it memorized within your subconscious. That's how to know it, is by memorizing the parasites. So let's go. Let's go. Keep going. Keep going. Keep going. Continue. Okay, wait. Now, I want you to identify these parasites. How many parasites do we have here? Who can tell me what parasites are here? That will make me know that my work today was properly done. If you can tell me, please come and take the microphone, or I can extend it to you. Okay. Modi. Modi, please come. Quick, quick, quick. I want to be sure that my work was properly done.
Okay. The one with the band is P. malariae, Plasmodium malariae. The one below it is Plasmodium vivax. Then the one above is Plasmodium ovale. No.
Thank you very much. So next slide. Next slide. Thank you very much.
Thank you. Thank you. Thank you again. Yes, sir. Thank you very much. I trust by that clapping ovation, it's well understood that we appreciated the presentation, true of us. I remember those days while I was working in the lab, and I had a problem with the issue of malaria. They said, you know they see malaria. So one day I now called the director and said, Oga, since now you they see malaria, you can't teach me malaria parasite. I prepared a slide, put it under the microscope, and it came and focused white blood cells, neutrophils in that matter. He said, see malaria. I knew. I said, is this malaria? He said, yes. I had to go to the internet, browse the picture of malaria, and I presented. Do they look like the same thing? Oga quietly walked out. He never come to challenge me on the issue of malaria again. So it's a big issue over there in the private setting. And just like I said, you can comfortably report what you have seen today, and the sky will not do what? The sky will not do what? This is empowering us. If you know what you're doing, nobody can threaten you. At most, is to threaten to sack you. Is it not so? In fact, I told one of them, okay, if you want to sack me, sack me. Again, let's put our hands together for that great presentation. And please, if you're part of those who wants to hate him, we are begging, from today, love him the more, so that he can give us good representation. Finally, in the next 5 minutes, we'll just take the last abstract presentation, and then we'll be saying the closing prayer. Nobody should come again for abstract presentation because I've come for it, and I only had 2 persons who approached me. So after this, we'll be saying the closing prayer. So I have the privilege to call on the presenter. He will be presenting on the topic, perceived effects of single parenting on youth of Ogbia local government area of Bayelsa State. Is no other person than Mr. Isaac W. Please, let's make welcome with a round of applause as he takes us to that journey. Thank you very much.
Thank you, sir.
Good everyone. Good everybody. All right. Standing on a ready established protocol. My name is Isaac. I'm representing the Faculty of Nursing to make this a brief abstract presentation on perceived effects of single parenting on youth of Ogbia local government area here in Bayelsa State. It's put together by Dr. Omar Edet, Dr. Dagogo Brown Igirigi, Iro Aya Lawrence, and my humble self is Isaac. Next slide. So when we talk about single parenting, what does it mean? Single parenting is a condition of caring and raising a child by one parent, either only by the father or the mother. It also refers as solo parenting. That is, one parent bears all responsibility of that particular child. Then we also have someone by name John 2020 talks about single parenting, that it is a social problem and it leads to none or adverse development of the country. Next slide. By brief summary, which we call abstract, this study was an assessment of perceived effect of single parenting on youth of Ogbia local government area, considering the psychological and social and academic dimension. We don't only consider just one area, but both the psychological aspect of the individual, the social aspect of the youth, and then the academic aspect, drawing upon a synthesis of existing literatures. 3 research questions were raised as the guide to achieving this study. Next slide. Okay, now data collected we analyzed using descriptive statistics, and same revealed that single parenting has an overall perceived negative effect on the youth's educational status, moral conduct, and physical development of the area. All negative.
Then the effect of single parenting on youth educational status includes the following, but not limited to: difficulty in attaining university level. You see many of them that are raised by single parent, hardly you find them attaining university level. Then they have poor academic supervision by their parent, because sometimes you might see that one of the parent that is parenting the child could even be an illiterate. Then low academic status. Next slide. Similarly, the effect of single parenting on youth moral conduct were also enlisted or find out that they come up with poor etiquettes. They have sort of misbehaviors. If they come around, you see so many lot of mannerism around them. Some of them will stay in the hall misbehaving, or you see them on the street, they behave like touts. Then also they have deviant behavior. They don't keep to law at all. Then they have this law-breaking tendency. Lastly, the effect on their physical development include inability to establish cordial relationship. They find difficult to relate with one another cordially. Also, economical effect, financial challenges is also one of their problems, and then lack of meaningful occupation. Now, when you go to the street, sorry to mention, the drivers are not actually poor people, but you see many of them that do what they call agboro on the road. They are product of this single parenting. Next slide, please. Then as a result, on our recommendation, we recommend that divorce among parents should be condemned culturally. Then parents, though while we have the legal right to divorce, but culturally, we can discourage that. Then parents should prioritize children's education as mandatory. It's unfortunate that the country we are, education is not really that mandatory, though it's in the book, but it's not actual, but it should be made mandatory. Federal government should declare free education. When you go out there, we all are aware how difficult these people, it's so difficult for them to be able to even pay school fees, not to even feed these children. Then also because we, in this Ogbia region, this is the major oil producing zone. So why can't the federal government prioritize free education for the children, so that those that are even raised by single parent will have the ability to achieve the university level of education. Then members' communities should maintain healthy and harmonious relationship. We recommend that this chaos inter-community disputes should also be discouraged, and state attend indigenous foremost concerning employment and rural development. Of course, some of these parents have nothing they are doing. So if at least one of the parents that is parenting the child has good thing that he or she can use to sponsor these children, they'll be able to stand fit in the society. Next slide. All right, I want to say a very heavy thank you for listening.
Thank you very much. I'm tempted to think that he was the school timekeeper when he was in secondary school. A round of applause for him again for keeping to time. Well, I think we have come to the end of the presentations. I want to believe we have one or two questions, and I would like to take those questions before we close for the day. So if you have questions, question number 1, 2, yes, I won't take hands after these ones now, so put your hands up now. 1, 2, 3, 4, 5. No other hand again. Thank you very much.
Yeah, all protocols duly observed. I want to sincerely appreciate the presenters. I mean, they have done wonderfully well, all of them. Very academic, very informative. So, and I want to sincerely ask Dr. Kelly, Dr. Fett, now that you are in the two fronts now, you might tell us how best to manage the situation, because this is a situation that is becoming highly problematic, and it doesn't help the health outcomes, because we do our work religiously as scientists, and then we are not looking for any trouble. But the only thing is we are expanding, and we have not even exhausted the horizon of medical laboratory science globally or in Nigeria. and getting worried like this? What about when we're exhausted like in any other parts of the country? So what do you advise, or what do you think we can do, yes, to mitigate the situation? That's one. Secondly, I want to sincerely inform you that we love you. We love you so much, and we also appreciate your honesty. And if we don't love you, we won't be here. Those we don't love, they don't see us. They will not be in our meeting or in our workshop like this. This is a mark of love and a mark of team spirit. You know, you are still part of us, so we appreciate you. Thank you, and God bless you.
What's love, please?
Okay, thank you most sincerely, my distinguished senior colleague. I'm grateful that you are here today. I know that one thing that those days I was away for a long time. I went to study, so that's why I have not been very frequent in national events and all that. But there's hardly any national event you go to, you will not see a banner. Whether it's election year or not election year, you see a banner saying, vote for, you see his name there. But today, he realized his ambition. Please, let's clap for him. He tells of doggedness, it tells of resilience, it tells of keeping your eyes on your goal, and you eventually realize it. So the question you asked me, I will answer you very honestly and most sincerely. This was the same question I was asked when I was going around 3 weeks. I came back. Let me put on record. Let me be put on record that honestly, I read medicine because I wanted to prove a point. Not necessarily because I wanted to go and practice it, especially in our hospital where I work at the Federal Medical Center in Egua. I felt I should make a statement. And when I went to medical school, I made sure I worked harder because I know many people were waiting for me to fail and be bundled back, especially medics, so that they can say, look at him, old man, he thinks he can read medicine and things like that. So what I did was, well, I was very close to my MD, then we were communicating, and my head of lab too. Each exam I went to write, I made sure that I aimed for a distinction. So I would forward the raw data of the result to the MD and also to Mr. Solomon, who was the head of lab, so they can be seen in real time what my performance was, because I was out there to make a statement. But I know that what it needs you to be a medical doctor is to get 50% in all your courses, all your tests, or everything, 50. And then you become doctor, and then your head becomes so big. So, and I know many doctors in FMC, perhaps, was 50 they got. So I wanted to get more than them. Very frankly. So that was how I was posting it, so he'll be seeing it. I will attach my photocopy, my ID card, asterisk he will see what others got, and then he will see what me I got. So I did that for the period I was at school, till my final MB. When I came back, the first thing he said when I entered his office, he said, Doc. He said, Doc, you made us proud. I said, thank God. In my mind, I took a deep breath. I said, thank God. Because without sounding immodest, I had over 23 distinctions out of 56 courses I did. 23. In my transcript, 23 distinctions. First MB, it was anatomy, physiology, by all distinctions. 3 of them. I was out for a kill. I wanted to make a statement. in my second MB, I had credits. Some of the credits, the only one you remember make it be decisional. Like pharmacology, 69. The other one has 65. You only needed 50 to scale through. Then in my last MB, I had a distinction, a credit, and a pass. So I did my best to represent the profession where I'm coming from very well. So when I came back, he said, I want to show you off to the hospital community. That was why I did that, No, it's not because that thing was anything. That thing he said I should go and do it 3 weeks. He said he wants to show me off that he has a homegrown doctor. Through his administration, he has developed. It's okay, it's fine. He said it will help me for my medical and data council exam. I said, okay, it's fine. So I went around. I went to internal medicine. That was where I started from. So I didn't introduce myself as a staff of the hospital and anything. And then the consultant was trying to, where are you? Who are you? Okay, foreign trained medical doctor, just came back. He thinks I should go around. He became hostile. When he had foreign trained, he became hostile because he thinks I'm calling him local. So now me, I'm foreign. I'm only saying I didn't train in Nigeria. He took the intervention of this boy. Now this boy that did IT, does the lab rotation. Steve, that is a senior registrar in the hospital. He was a technician. He now went to Belarus to read medicine. He came back. So the guy is also in internal medicine. He came around, do one word round. He said, Oga, you are here. He came and said, this is my Oga, was my Oga. The man turned, you know him? This is one of the big man in lab. I said, why didn't you tell us now that you are in this thing? I felt very bad that day because he was not treating me well. He would give me an X-ray to read. I would start. I was trained by Cubans, so actually. Both of my lecturers were Cubans. The way he said, no, have you seen X-ray before in your eyes? Can you see X-ray with your naked eyes? The usual bullying and harassment. He said, you call it chest radiograph. It's not X-ray. It's not chest X-ray. You cannot see X-ray. Then, okay, tell me, how do you diagnose heart failure? I said, well, you have. I started. He said, no, you must say this one before the other one. If you didn't arrange it that way, the way I have it, how do I know what the way he has the arrangement in his mind? So I saw all that. Then I reported him to Dr. Mubo. He said, you made a mistake now. You didn't introduce yourself very well. You're a deputy director for that matter. Doctors respect big people. So tell him your status. That's why he was taking you for granted. Any department you go, tell them you're a deputy director, you worked in this hospital for 20-something years. Say you're going to earn your respect too. I said, okay, no problem. I went to O&G, the next place. After the morning review and all that, the chief registrar came to do that's their routine. That we have a new person in our midst, blah, blah, come to the front, and I started. I said, I'm a foreign trained medical doctor, trained in the University of the Gambia. I'm back. I'm here for like 2 weeks to understudy how medicine is practiced in Nigeria at the instance of the MD and all that. I worked in the lab for over 20-something years. It was 2022, about 24 years. And I worked in medical microbiology, parasitology department. And I'm here today. Almost all consultants, their hands were up. Because the junior people don't talk where the senior people are. The sitting arrangement is back. If you are just junior, you are in the back. Well, they respected me. They gave me a seat in the line where the registrars are. Maybe it's my age they are respecting, I don't know. So, their hands were up. The first person said that, yes, I want to know, are you Joesu or NMA? Tell us, which one are you? That's my question number one. I said, well, I come in peace. I come in peace. I have come to bridge the gap between Jehesu and NMA. Because, I told them, because where I am coming from, there is no Jehesu, there is no NMA. All you have is one medical team working for the betterment of the patient. That's the climb I'm coming from. That's how I was trained. You be in the theater, be performing something, everybody is there happy. When they finish, they sit on the same table and drink coffee while they are waiting for the next patient to be, during break. Whether you are the cleaner who was cleaning the blood that was blood spillage, everybody sat on the same table. They didn't know anybody, they didn't know what made, they didn't know cleaner, they didn't know scrub nurse, they didn't know, but it was same. That was the training I got. I said, I come in peace. I have come so that everybody in this hospital work for the betterment of the. So that will say, it's okay. Another one, your friend, Dr. Opara. I know your friend. Your lovely, I think. Good. Take the microphone. So, okay, tell us. We hear that your people have sent a bill to National Assembly to make it difficult for only doctors to be called CMD and MD. Now that you have read medicine, you are now in the medical profession, and you're also a lab scientist, tell us sincerely, from knowing these two, who is more properly placed to run a hospital of this nature? Yes, so that is why I find it ridiculous. I find it very ridiculous because I cannot rubbish medical laboratory science and medical laboratory scientists before doctors. I can never do it, because that is saying that what they think I have in excess of them is nonsensical. That's what it means. Why would I do that kind of thing? Rather, I make them believe that if it was not bad lab science, I could not even be in your midst. But then it bleeds my heart when people who you think are supposed to cherish the profession very well are the one running down the profession by saying some people qualification is substandard, and then some are, meanwhile we are licensed by the same Medical Laboratory Science Council of Nigeria. It beats my imagination, because not too long somebody has said my AMLT is equivalent to HND. Somebody we thought knew better came publicly in the official page and was writing those kind of things, that my AMLT is just equivalent to HND. And then me, who has got MBBS, cannot even say it, because I know the value of what I got in the AMLT. So what are we talking about? So sometimes the problem we have in the profession is caused by our people, because of the way we talk and misrepresent issues for peculiar benefits, what we want to achieve at a particular moment. So I told them, you want to hear the truth from me? Say, please tell us the truth, because we don't have the privilege of being a lab scientist and doctor at the same time. I said, okay, I'll tell you the truth. The truth of the matter is that neither you, medical doctor, or a JOS member that knows no jack, he has no stint in administration, has no business sitting on that seat to say he wants to run a hospital. That's what I told them all. Opara is your friend. If I am lying, when you leave, go ask him, say, when they put this question from, what did I answer them? So that if you look at that, I came here to make up stories. He was one that asked me that question. This was the answer I gave to him. I told him, I said, personally, I knew that someday I would up there and I would have to be handling administrative. I went to study public administration. I think you saw it in my district. I did postgraduate diploma in public administration. I did masters in public administration far back as 2001, 2003. Because I know someday I'm going to be a deputy director or even a director. So I should know how to direct, how to elicit policy, how to make decisions and things like that. And I told them, when you sit in that office as MD, you are not prescribing any paracetamol to anybody. You are only harnessing human resources, economic resources, and material resources made available to the hospital for the benefit of those who come to access service in the hospital, which are the patients. So you cannot arrogate the knowledge or the expertise of administration to yourself if you have not gone through the crucibles of learning administration. And persons have gone to university and they read administration. And that was why before Decree 10 of 1985, only house governors headed hospitals in Nigeria. And where I am coming from, where I trained in the Gambia, no hospital is headed by a doctor apart from Edward Fan's Small Teaching Hospital. So one of them was nodding. He said, yes, I. And they have better health indices than Nigeria. So what are we even talking about? So a JOS member who is a male lab scientist that has not read administration cannot vie to run a hospital, as well as a consultant who has read medicine and specialized in orthopedics. It does not translate to knowing how to run a hospital and manage a hospital. So if you want to become MD, CMD, go and do what I have done like 20 years ago. That's what I told them. That's how the matter ended. So my distinguished senior colleagues that have asked me this question, I'm on a mission to challenge all of us to build capacity. Incapacity is power. Incapacity is, authority. Because when you know, people cannot toy with you. So capacity is key. Knowing your work and knowing it very well at your fingertip. I didn't cram what I came to talk to us today. I knew it. It's inside of me. That's how we should know our various areas of calling. That's how we should know it. And if that happens, fight will end naturally. Fight will end naturally. Respect will become mutual. And everybody will be in peace. God bless everybody.
Thank you very, very much. Let's get the next question.
Thank you very much. Standing on the existing protocol, I sincerely want to appreciate the organizers of this program for getting good resource persons. I came from Port Harcourt. I spent my money, took the inconvenience on the road. I'm spending the time, and I am not disappointed. Before I registered for this, I told the person that I was talking with, I said, please, I don't want to be disappointed because I value this time I'm going to spend here. But I'm very happy, I'm not disappointed. The next thing I want to say is that our moderator, you've been talking about the private sector. I want to boldly say that I'm in the private sector. And that's part of the reason why I'm here. Because I am a medical microbiologist, as a med lab scientist. By God's grace, I'm very good in it. When you employ, in fact, when you employ new graduates, I don't know whether I will say new graduates, let me just say when you employ lab scientists now, you will need to teach them. And I try a lot to teach the microbiology and the other things I know very well. But you see film reading, I don't know it. So I've always been having good hematologists, and recently you cannot get wrong. I don't know why, maybe because of automation. And it's like a challenge. When I was talking to Professor Jerry this morning, as you said, I say, these children will put somebody into trouble. Let me come and renew my knowledge so that when you are giving out your results, I will be able to know you gave a wrong result. So I am very glad I'm not disappointed. Somebody said here today that talking about teaching, it's not in the private sector, please, it's from the school. When they come out and they know what they are doing, they would do well in the government sector, they would do well in the private sector. And again, a lot of those things you see in the private sector, you see them because it's like somebody that is running solo. Nobody moderates it. Those people that give out those kind of results in the private sector, they do it in the government sector also. But the difference is that there is a head, that supervises. So that's just the difference. And in the private sector, I still want to say that there are those that are doing very good job. I know there is a case where one of our clients, he came from US, he's been having diarrhea very often. They diagnosed him of colitis. And then he came and said he complained. I said, do your stool microscopy. When he brought his stool, there was a lot of gel in the stool microscopy. I reported it. He said, what? In US, they've done this 3 times and they said nothing. I said, but it's obvious. Okay, your wife is a professor in microbiology. I know it's microbiology. Tell her to come to the lab. I'll mount the stool. Make another stool. I'll mount the stool. Let her see it. She came and she saw it. While she was seeing it, she was, it's so plenty. See them this way. See them there. I said, look at it. Watch out for the falling leaf movement. Look for the giardia. All she knew about it is that she's looking for the big eye. And I told her that's understained film, that you would see that. But see this, and what you will see. She saw it. She was quite convinced. But when she left, they reported to the doctor abroad, and that one ruled it out. And they came again and said, Madam, you didn't see anything. It was Brown motion. I said, no problem. But for me, I know it's giardia all over the slide. So what I'm saying in essence is that, please, let's try and teach these people very well, so that when they come, they can still do the work well, so that this one that he's talking about, insult to the profession, will not be there. Thank you very much. So again, please, to the presenter that presented on microscopy, urine microscopy, is it? So please, in the crystals you spoke of, I didn't see oxalate crystal. Is there anything like that? And I want to say that in practice, you see it so often. You see it more than any of those other crystals you're talking of. And one experience also I have had is that when the urine has overstayed, you see the oxalate crystals more. So I don't know, could you please enlighten us on it? Then on doctor, you said when you see any malaria parasite outside the blood cell in thick film, it's not it. In a case where the Schizon has burst the red cell and it is on the film there, do you disregard it? Those are the 2 questions I have. Thank you very much.
Thank you very much. Let's take the questions all so that they can answer.
Thank you very much. Doctor, please, I have a question, a real-life question. A colleague did a malaria test and then he recorded no malaria parasites in the hospital. But later, the doctor approached him and said, we followed the symptom of the patient and treated malaria for malaria. And then we found out that, we concluded that the patient was having cerebral malaria. So the colleague is confused and wondering, is there a way we will do the film and then we'll see no malaria parasite, but there is a case of cerebral malaria? There is a way the malaria parasite can cross the blood-brain barrier without us seeing it on the film when we do a normal film. So that's the scenario. It was confusing. I said, okay, when I come here, I'm going to ask this question. Let's know if there is any form or any way of that happening. Thank you.
Thank you. All your questions are noted. Let's take them all so that we expect answers. All right, I think I have 2 persons here.
Good afternoon, sirs. My name is Robinson. I wanted to know something from the lectures that was delivered by our amiable doctor, Dr. Faith. In the course of your lectures, there is something I was looking at for that I didn't hear, which is a quantitative buffer quote. I don't know if that's also invoked as as a recent time currently as one of the tools to diagnose malaria parasites. Because I've seen a situation whereby I have also done it, but not too proficient in it. So I was looking out to see more recent knowledge on this aspect, which was not touched in this lecture. So I don't know if you can throw more light, or if it's not invoked, then we can just let it. Thank you, sir.
All right. Good afternoon, sir. All protocols duly observed. My name is Ruben Daniel Arayanziba. My question is based on the staining for malaria parasites. We were taught that the principle of staining, the acidic stain, will stain the basic part of the cell, while the basic stain will go for the acidic. So I want to know, for malaria parasite, we observe the opposite, where the methylene blue will stain the cytoplasm and the eosine will stain the chromatin dot. So I want a clarification on the staining principle for malaria parasite. Thank you very much, sir.
Is that all the questions? Okay.
Okay. Well, coming to the question about oxalates, if we take everything we can see in urine, we can't finish it in 1 week. We have a lot of things in urine. One problem we have in this part of the world is our inability to specialize. Overseas, you see somebody, his work only is to analyze urine on microscopes, and that is what he's known for. Samples come from different parts of the country to him because he is an expert on that. Here we tend to do everything, and trying to do everything, it becomes difficult for us to master a lot of things. I intentionally left that because it is one of the commonest things that we see, which all of us know. I decided to look at those uncommon things that we don't know and we don't usually take note of. Like some of the things we see there, the microbiologist may give it a different name because he or she may not really understand what it is. Calcium oxalate crystals in urine, they are significant. They could be from diet, high diet from food containing oxalates, which combine with calcium in the body to give you the crystals, but they can be indicative of different pathological conditions. It can indicate dehydration. They can equally indicate formation of kidney stones. So if you see calcium oxalate in somebody's urine, please report it because they are actually significant. Let me tell you something. There's something I always say. I know I didn't say it when I started, but I want to say it now because we are colleagues. If everything we have learned today, you can't move forward with it. You can't make a living from it. You can't make money from it. Then you have wasted your time. Urine microscopy alone can give you a lot of money. With 350,000, you can start a place. You do only urine microscopy. Get a centrifuge, get a good microscope. That's all. You become an expert. You become a consultant in urine microscopy. People will come, send samples to you. There are things I don't like to talk about myself, but I've dropped something for us to understand. Thank you.
Oh, it's my turn. No. Yeah, okay. Please sit down. When I'm done, I will. Thank you very much for your questions, seeking clarifications. That Shizons could burst, and then you are expected to see it in the film when you stain your film. No. If you remember, even your arrest cell that contains the Shizon or tophozoite, as the case may be, that is not preserved, that is not, you didn't alcohol fix it. When you stain, it will wash off. So why should the Shizon be there? So you can see it. If the Shizon is there, it should be inside the vessel. So, and if it's not in the red cell, in the thin film, you should also see other Shizons that are clear, very clear, within the red cell that helps you make your diagnosis. So, in malariology, that's why when even you see a parasite in the thick film, and we think it's parasite though, but it's not many. So you can see different varieties of it. Maybe you're seeing like maybe low parasitemia. You see maybe 2 parasites after you've searched and searched and searched. And also, the slide is not even a very good one. Scratched here and there with artifacts. Things that can actually mimic parasite. So quickly you go to your thin film and you scan and scan and scan. You didn't see anyone. It's very unlikely that those 2 things you saw in the thick film are parasites. So in the same vein, because the thick film will lyse the cell, and then expose the parasite. In the so if you are seeing you can see Shizon in the thick film, but then you should also be able to see it in the thin film when you cross-check your thin film. And if you're very knowledgeable of what the Shizon is, what I'm trying to say is that you will not see Shizon outside the red cell in the thin film preparation. That's what I'm trying to say. That in the thin film you should see the parasite within the red cell. Because what will make it not inside the red cell after you have stained. So in your thick film you can see schizon stages. I showed us some schizon stages in the thick film. If you know the morphological characteristics of the Shizon, you will know that this one is Shizon. You cross over, you also see at least a witness that what you're seeing. That's the beauty of having the 2 on one slide. So I hope that tries to explain that. So severe malaria with no MP. I started by saying that the reason why we decided to do this because we want to be able to let the doctor make that diagnosis of severe malaria. And severe malaria, you cannot make that diagnosis if we have not seen, if the medical laboratory scientist has not told you that the blood you send to the lab contains asexual stages of the parasite. That is WHO definition, standard, how the doctor must define the case of severe malaria or communicated malaria, as the case may be. So if the scientists have said no MPC, probably because one, the scientist has not done a thorough search, but it's not in all cases actually that you see parasite everywhere, so the scientist has not done a thorough search because some of them are very lazy. You just do the thing, shaka shaka shaka, you report something. So you need to search, you search very well, so to be able to say you saw or you didn't see. So if the scientist has done his job thoroughly, then it was not a case of severe malaria we had in our hands. But I also said there are a lot of things that give you the signs and symptoms you would have in severe malaria. What are the signs and symptoms? Clinically, there will be confusion, there will be prostration, there will be, altered sensorium, there will be respiratory distress, all that will be there. Then if you check the laboratory side, you will see jaundice, you will see low urine output, you will see electrolyte derangement, you will see lactic acidosis, all that you are going to find. And in addition with disseminated intravascular coagulation or coagulopathy, you see all that. So, but this, what I have casted now, can also be found in other conditions that are not malaria. So if this thing the doctor saw was coming from malaria, then you should see the parasite, the sexual stage of the parasite in the blood. You should see it if you know what the parasite is. I think that's the essence of this seminar. Somebody talked about Buffy coat for malaria test, diagnosis, microscopy. I don't know why you want to go through the route of, how you get Buffy coat. You will first put in the capillary and also put in the hematocrit centrifuge, then take the risk of trying to cut that particular segment where the Buffy coat is to put on the slide. And also, is that not how you do it? Is there any other way you generate the Buffy coat? I don't know. Because we in filariasis, you don't even need to break. You just put the ears and then you check. You see it's swimming there. You get it. But then if you want to, so you check. But that's not for MP. The Buffy coat thing that I know, all my training and working in the lab, is not for MP. MP is your thick and thin film, which is gold standard. That's the gold standard till next tomorrow. So anybody doing Buffy coat, I don't know what the person is doing. I don't know if there is a material to that place. Let me extend to me. But I don't even know the sense in it. Why I want to go that route when you can make your film properly and stain with ginseng stain, and then if the parasites are there, you see it. Why do you want to go to Buffy coat? Well, I don't know. It may be a new thing. I'm not aware of that. I'm sorry. So MP staining. Somebody asked about why the differential, the reverse in what you used to know for Romanowski stains and all that. Well, there is always an exception to the rule. For malaria parasite, it is an exception to that rule, where acidic part of the cells is stained by the basic aspect of the dye, and vice versa. I've encountered this question a couple of times, and we also asked this question when we went for training. There is no better explanation I was given other than there is an exception to the rule. For the malaria parasite does not obey that known rule. I think that's all I have here. There are 4 questions, and I think I've attempted to answer them. Cerebral malaria is a type of severe malaria. Why not? You should see it. Because it was in the blood before it crossed the blood-brain barrier to affect the individual. So you should see it. The malaria parasite spreads in the body through hematogenous spread. It's through the blood. In pregnant women, we know about sequestration, when the parasite decides to sequester into the capillaries because of the adhesion that happens in an infected red cell with antigens that can be bound to some receptors in the capillaries, in the endothelium. So at that level, they sequester there and all that. But the ones that got to the brain and gave a cerebral malaria should also still be in the blood. So I don't see any reason why. Otherwise, how would you make the diagnosis? the criteria for diagnosis is that you must see asexual stages of the pus in the blood. Not the one that is sequestered. In the blood, you must see it before you can say, the doctor can say he saw or he's treating. But you know, what happens in most cases is that sometimes the doctor thinks that you are not correct. And you too, because you have maybe some doubts, you might not be able to put your feet down and say you didn't see. So the doctor can expand in making his diagnosis. You get it? You must see the parasite, asexual forms of the parasite in the blood. You can check that out at the end of the day.
Thank you very much. I think he needs a round of applause. The council rep would want to send the greetings of the registrar to us. So I think after that, we'll be done for the day.
Thank you very much. All protocols duly observed, but I still want to, recognize some persons here, especially Prof. Agiti and Dr. Agoro. Doctor that's also presented here, I want to say a very big thank you because I've learned a lot. Seriously, I've learned a lot. And I'm here to just say one or two things as instructed by the Registrar of Medical Laboratory Science Council of Nigeria, Dr. Tosan Eyabe, reappointed. Let's please put our hands together. Yes, he's aware of this workshop and he's saying that in due course you will get your certificate well signed. We want to also inform for those of us that are in Bayelsa here that Medical Laboratory Science Council of Nigeria, we are trying hard to get an office here in Yenagoa. So we want to say if you have any good information for us to secure a space in Yenagoa, please help us out. We really appreciate because we want to bring down MLSC to Yenagoa, to Bayelsa. Because even in your licenses, you can recall that you're not getting the hard copy. It's the soft copy you're seeing in your mails and all that. So it will really help us if we have an office here. And then we also want to say that your annual license is very, very easy for you to get. Gone are the days where we want to pass through somebody to do it for you so that before you get more. Just log into your portal, pay the necessary dues. If you have CPD, you will probably contact me and then we'll send it, collect the CPD and then we'll send it. And if you don't have it, you pay for CPD penalty and then you request for your license. You will definitely get your license. That's how it works. Now, most importantly, why I really handle this mic is because of MLSC EQ program for those of us that are in private practice. MLSCN is offering an EQ program that is very, very important. And as medical laboratory scientists, it is important. As a matter of fact, the council is looking at trying to accredit every laboratories that have been registered. And then before that will happen, the person probably must have passed our EQ programs. So please, we encourage everyone who are practicing, who are into medical private practice, to please key into our EQ program. Thank you very much. If you have any question, please, after the year, you can meet me and then we'll talk about it. Thank you.
Thank you very much for that wonderful message from our great registrar. I think at this juncture,
thank you very much. Thank you very much. Thank you very much. I really appreciate my mentors, Mr. Hoxton and Dr. Faith, for turning up, people that trained me. Thank you very much. Also, I appreciate colleagues that came from other states. I can cite 3 of them here. I can also cite my leader, Mrs. Justina, my senior in school. Thank you very much for coming. Tomorrow is the last day and it's hands-on. It will take place at the Faculty of Medical Lab Science Teaching Laboratories. Just opposite this place, down. That is where we are going to use for the hands-on. Also, we'll start by 10 so that by God's grace, as early as 2, we should be done. So please try to keep to time. I want to use this privilege to appreciate and thank the chairman organizing committee, the secretary organizing committee, and all staff of the Faculty of Medical Lab Science for the sacrifice. Also the participants for deeming it necessary to come and attend. The resource persons, thank you very much for a job well done. I also want to thank the MLCN representative, my leader, Mr. Romeo. He keep calling me, and I love his dexterity. I love his humbleness and sincerity of purpose. You are welcome to Federal University Otuoke. We are known as the family university. And by this time next year, we are going to again invite you for our second edition of our of our faculty conference. I believe that you will turn up. Next year will be more robust. And in a moment from now, we are going to invite you to our faculty public lecture. And by last week of June, we are unveiling our maiden edition of our Otuoke Journal of Medical Lab Science. We've gotten about 15 articles. So even though you didn't turn up, you didn't give. So based on that, we have sufficient article to rule out the edition. So if you still have an article you want to submit, just visit our website, university website. The email address you attach the article to is there. It's just 20,000 naira. Instead of paying international journals $100, which translate to 170,000 naira, you can use our journal. After all, university-based journal is ranked higher than floating journal or other institutional journals. So thank you very much for coming. The Vice Chancellor said I should thank you and appreciate you. God bless you for coming. Thank you very much. Call on anyone that is very close to God to lead us in closing prayer. The closest to God.
Thank you very much, my dear. He always loved those who are closest to God. And running through my mind now of the next person closest to God after my HOD is Dr. Wika. Good news. Is he here? Please, Dr. Wika, take us through the closing prayer. Thank you very much.
Can we pray? Father in heaven, we give you all the glory for the wisdom and in the knowledge you're giving to this faculty, all our facilitators, and the grace you're giving to us from the outset of this conference into this moment. I thank you for the success of today. Father, whatever we have learned, we pray that you grant us the grace to implement it, to maximize it. As we live here, Lord, for your presence, guide us with a guiding grace and cause your inner wisdom to perfect our ways and our days. As we bring us back tomorrow, we'll see a more glorious mode. Thank you for this and others. We pray in Jesus' name.